The Subcommittee on Health will now come to order. Due to COVID-19, today's hearing is being held remotely, and all members and witnesses will be participating via video conferencing. As part of our hearing, microphones will be set on mute to eliminate background noise, and members and witnesses will need to unmute their microphone each time you wish to speak. Documents for the record should be sent to Megan Mullen at the email address we've provided to your staff. All documents will be entered into the record at the conclusion of the hearing. The chair now recognizes herself for 5 minutes for an opening statement. A U.S. law prohibits Medicare from negotiating directly with drug companies. We're the only developed country in the world with such a law, and because of that, Americans are paying 3 to 4 times more for prescription drugs than other countries. We can change that, and if we do, we'll not only save lives, we'll prevent bankruptcies across the country. In the absence of direct negotiation, American prescription drug prices have gone up year after year, while large drug companies saw huge profit margins of about 20% on average. These price hikes have caused Americans to choose between buying their prescriptions, paying rent, and buying food. For example, 1 in 4 diabetes patients report rationing their insulin. 30% of Americans have skipped a medication dose due to cost. The Council on Informed Drug Spending Analysis has estimated that by 2030, 1.1 million Americans will die prematurely due to high out-of-pocket drug costs. Every member of this committee has heard from their constituents about high prescription drug costs. Today, our subcommittee can help them by moving H.R. 3 forward, the Elijah E. Cummings Lower Drug Costs Now Act, obviously named after our beloved colleague. H.R. 3 will finally give Medicare the power to negotiate lower drug prices for drugs that have no market competition and extend those lower prices to all Americans. The legislation caps out-of-pocket spending on drugs at $2,000 for Medicare beneficiaries. Today, seniors can pay more than $15,000 a year for a single prescription drug. During our markup of H.R. 3 in 2019, I added a provision to the bill to cap how much seniors with high out-of-pocket costs pay per month to $250. H.R. 3 will also stop drug price hikes, like the ones we saw from EpiPen and Martin Shkreli. If a manufacturer raises the price of a drug, including generics, above the rate of inflation, then the manufacturer must pay the entire price above inflation back to the Treasury. Nonpartisan analyses found H.R. 3 will reduce U.S. drug prices for negotiated drugs by 40 to 55% on average, save the federal government and taxpayers $500 billion over 10 years, save patients $158 billion in lower insurance premiums and out-of-pocket costs, and save private businesses $46 billion. With these savings, we can make a major investment to kickstart drug research and development at the NIH, FDA, and the Advanced Research Projects Agency for Health, ARPA-H, which the President described in his address to Congress last week. These investments will support the development of innovative cures that will be available and affordable to all Americans. This bill is popular, and it's bipartisan across the country. In an April poll, 93% of Americans support giving Medicare the power to negotiate with drug companies for lower prices. AARP, the American Hospital Association, the American Medical Association, the Purchaser Business Group, and the AFL-CIO all support H.R. 3. A recent poll of executives from 300 large private employers found that 72% agree that a stronger government role is needed to negotiate prices for high-cost drugs. This bill could be bipartisan. In Congress, there's been bipartisan support for the VA's direct negotiation authority for 30 years. Several provisions at H.R. 3 are similar to the Senate's bipartisan bill from the last Congress. The last Republican president also supported negotiating drug prices, but didn't deliver on it. I think it's time to live up to our promises to lower the cost of prescription drugs for all our constituents. The chair now recognizes Mr. Guthrie, our wonderful ranking member of the subcommittee, for 5 minutes for his opening statement. Please.
Thank you, Chair Ashley, and thank you for holding this important hearing. I am very concerned about the consequences of Speaker Pelosi's partisan drug bill H.R. 3 that's before us today. There is no doubt that Congress must do something to lower prescription drug prices. We know the American people want lower prices, but they do not want to sacrifice access to life-changing treatment. H.R. 19, the Lower Cost, More Cures Act, that I helped introduce would lower prescription drug costs while protecting innovation for new cures. We also know the American people do not want their Medicare taxes and premiums they pay diverted to liberal PEP programs, which I'm afraid is the direction H.R. 3 is headed. Speaker Pelosi's bill brings us one step closer to single-payer healthcare systems. Supporters of single-payer often cite healthcare systems around the world as examples that the U.S. should follow. However, I believe single-payer systems are a very dangerous idea. In the United States, we have access to cutting-edge, innovative drugs and the brilliant scientists and companies who develop them. The key word here is access. Under H.R. 3, we would be forced to sacrifice this access for more bureaucracy and fewer cures. A partial estimate from CBO said H.R. 3 will result in 15 fewer new drugs developed, and the White House Council of Economic Advisors under the previous administration estimated up to 100 fewer drugs. 2 years ago, when we first examined H.R. 3, one of our colleagues said in a hearing that he was willing to forfeit the CBO estimated cures that would not be developed due to government price setting. I challenge my colleagues, would you still agree with this statement, knowing that one of those forfeitures could have been the COVID-19 vaccine? Last week, the White House announced that 100 million Americans, almost 40% of U.S. adults, have now been fully vaccinated against COVID-19, and 55% of U.S. adults have received at least their first shot. America is in a very different spot than our allies in Europe, who, due to their single-payer systems, prioritize price over vaccine research and development and innovation. Thanks to President Trump, America took a very different approach than our European allies. Through Operation Warp Speed, we partnered with private industry and invested in research and development. We have the results to our approach to prove it. 3 safe, effective vaccines rolled out in record time. These vaccines have allowed our country to open and move forward. H.R. 3 disincentivizes research and development, and had it been in place last year, could have led to a worse outcome for all Americans in the fight against COVID and the race to a viable vaccine. There are bipartisan solutions to lower drug prices, including H.R. 19, the Lower Cost, More Cures Act, that will level the playing field for American consumers while still allowing for vital innovation that Americans depend on. Just last week, President Biden said in his joint address, and I quote, "Now, if Congress won't pass my plan, let's at least pass something we agree on," unquote. I think that's exactly what the American people want us to do. There is room for bipartisan action to lower cost. H.R. 19 is all bipartisan policies, and I am particularly interested in value-based agreements and Medicare Part D reform. These 2 areas have strong bipartisan support and would positively impact the lives of millions of Americans. I would like to yield my remaining time to Dr. Burgess.
Thank the gentleman for yielding. Of course, we did have this debate in October of 2019, but so many of us know we serve in the People's House. In many ways, this is the People's Committee. And in this committee, we do have a history of working both sides of the dais together for things that are important to the American people. So I certainly appreciate for an issue that HR 19 has been included in the list of policies that we're discussing today, because it does include bipartisan drug pricing policy solutions that, in fact, could be signed into law tomorrow. In fact, 17 policies from HR 19 from the last Congress have already been signed into law. And of course, there were several Democrats who voted for HR 19 on the House floor when it was proposed as an alternative to HR 3 in October of 2019. HR 3 did not become law. It did not become law because it is a partisan exercise and will limit patient access to treatments and cures. Parts of HR 19 did become law because they were bipartisan and they do improve patient access. Let's do what the president has suggested and pass what we can. And Representative Guthrie is exactly right in making that request. And I'll yield back to the gentleman.
The gentleman yields back. The chair now is pleased to recognize the chairman of the full committee, Mr. Pallone, for his opening statement. 5 minutes.
Thank you, Chairwoman Eshoo, and thank you for this very important hearing. I really think that healthcare is still the #1 priority for the American people, and within that context, lowering the cost of prescription drugs is the biggest priority. So today, we're considering HR 3, the Elijah Cummings Lower Cost Drug Costs Now Act, and other legislation that will provide much-needed relief to Americans who are fed up with the outrageously high prices of their prescription drugs. And I'm pleased we're holding this hearing to highlight once again why we must act and why HR 3 is the comprehensive solution this country needs to fix our broken market for prescription drugs. For too long, Americans have been forced to ration their medication, go without, or exhaust their life savings in order to afford the drugs they need, all while large pharmaceutical companies continue to make record profits. Americans pay 3, 4, or 10 times the amount that people pay in other countries for the exact same drug. And how is that fair? It's not. In fact, it's outrageous. And it's long past time that we negotiate a better deal for Americans. Now, HR 3 gives the Secretary of Health and Human Services the ability to negotiate lower drug prices directly with drug manufacturers on high-cost prescription drugs that don't have any competition. The Secretary negotiates lower prices on behalf of Medicare, but those same lower prices will be available to all Americans with private insurance. HR 3 also stops unfair and unjustified price increases by requiring drug manufacturers to pay a rebate if they increase prices faster than inflation. The bill also caps Part D out-of-pocket costs for Medicare beneficiaries, so they pay no more than $2,000 out of their own pockets a year for their prescription drugs. HR 3 provides the reforms we need to lower the cost of prescription drugs and uses some of those savings to reinvest in efforts to find the next scientific breakthroughs at the National Institutes of Health and improve drug review at the FDA. And HR 3 will save consumers and taxpayers billions of dollars, and it will lower healthcare costs and premiums while also improving health outcomes. In fact, the Congressional Budget Office estimates that HR 3 will reduce drug prices. The estimated cost of health insurance will also be reduced, leading to more take-home pay for workers. CBO also determined that the Medicare program will save $42 billion in other healthcare expenditures because beneficiaries will be healthier since they'll be able to afford the medication and take them as prescribed. And HR 3 will have a tremendous impact on the lives of everyday Americans. People like Teresa or the Ball, who's going to testify before the committee today, her experience, while unfortunately not unique, encapsulates us so clearly why HR 3 must become law. The medication Teresa relied on to treat her multiple sclerosis, as she will tell you, wiped out her savings. Eventually, she was forced to stop taking this medication because of the cost, even though she knew she would face health repercussions as a result. I just don't believe that any American should have to choose between paying for the prescription drugs they need to stay healthy and other basic necessities like food and rent. As President Biden noted last week during his joint address, it's long past time that Americans are no longer saddled with higher drug costs than people in other countries. It's long past time to negotiate lower prescription drug prices for the American people, and I look forward to moving HR 3 through the committee once again and for it to become law this year, as the president suggested. In addition to negotiation and stopping the inflation of drug prices, we also know that competition is key to bringing down costs for Americans. In 2019 alone, patients in the healthcare system saved more than $300 billion due to generic and biosimilar competition. So today, we're also discussing several other bills that will increase competition. And we'll hear from our witnesses today about finding comprehensive solutions to high drug prices and why that can no longer wait. So I'm pleased that we're considering all these legislative proposals today, and I'd like to yield now a minute to the gentleman from Oregon, Kurt Schrader.
Thank you very much, Chairman Pallone, for the time to speak today in favor of a couple of bills I have here before the committee. The BIOSIM Act is a common sense approach to increasing the utilization of biosimilars in this country. As we'll hear today, biologic injectable drugs are very expensive, and increasing the use of generic biosimilar forms will decrease patient costs. The Blocking Act is also a market-based reform to ensure generic competition in the drug marketplace to decrease costs to patients. In the current system, some generic manufacturers delay bringing their drugs to market by parking their applications once being awarded exclusivity. Doing so blocks other generic drugs that are actually ready from coming to the market and delays these less expensive drugs from reaching our patients. The rising cost of drug prices is deeply impacting all Americans. It's time to move forward with policies of broad support, and I yield back.
The gentleman yields back. Thank him for his work. I would just add a source of pride to me is that I was the author of the biosimilars legislation. So thank you. The chair now recognizes the ranking member of the full committee, Representative Kathy McMorris Rogers, for your 5 minutes for an opening statement.
Thank you, Madam Chair, and to our witnesses for joining us today. The story of American innovation is one that should be celebrated, bringing hope and early access to the most life-saving, life-changing treatments in the world. In the case of Crystal Davis, who will share her story today, it saved her son's life after doctors diagnosed him with spinal muscular atrophy with no chance of survival. Crystal and parents like her who have a child with a rare disease, they are fighting for the promise for the next life-changing cure and treatment. I'm certain that we've all heard stories before from caregivers and patient advocates like Crystal. We've listened to people who want a fighting chance at life. That fighting chance came with the American way, freedom and opportunity. Take Alzheimer's, for example. We need major breakthroughs to transform how we treat this disease and slow its progression. It would lift one of today's biggest cost and care burdens on both families and our healthcare system. It's more than just hope. Whether it's a rare disease like SMA, cancer, or Alzheimer's, or another dementia, new cures and treatments are a very real possibility if we can protect and spur the private investment for more discoveries. That brings me to Speaker Pelosi's government price control scheme before us today. It's a false choice, forcing us to jeopardize cures and breakthroughs in the name of saving money. According to CBO experts and other of the Speaker's own colleagues, it would result in dozens of fewer cures. Last Congress, the White House Council of Economic Advisors said it would lead to as many of 100 fewer drugs over the next decade. What could one of these cures or treatments mean? We don't know, but we know that if this becomes law, we'd lose hope to cure cancer or treat generic conditions. We'd become more reliant on China. And then, if those discoveries are even made at all, we'd be relying on a federal bureaucrat, someone in Washington, D.C., to let us have it. Like in Canada, the UK, or other countries, the power would rest with the federal government to crudely measure lives in dollars and cents. I just heard about a family in Canada. They have 2 boys, both with cystic fibrosis. Their 10-year-old has his medications. For their younger son, they're forced to painfully beg the government for his treatment. At first, the government just said no. Now they're being told their 8-year-old son must drop 20% of his lung function within a 6-month period. The mom said He has to become really sick to qualify. She said, quote, I compare it to waiting for a person to go on a ventilator before you give them the COVID vaccine, or waiting for a person to reach stage 4 cancer before you treat them with chemo. There's nothing just about a system like this. It discriminates against people with disabilities and chronic illnesses. The pre-existing conditions, those with pre-existing conditions. The National Council on Disabilities has warned us about the approach that's laid out by Speaker Pelosi, that is harmful, it's discriminatory, and it will be harmful on the most vulnerable. Unfortunately, this is the socialist healthcare system and the future that Speaker Pelosi is imposing upon us. Instead of price controls, we should focus on areas for bipartisan work. We agree, seniors and patients are paying too much out of pocket. Let's address that. We've seen the benefit of innovation in the fight against COVID-19. Now more than ever, we should be working together on American solutions, uniquely American solutions that save lives, lower costs, and uphold the dignity and the right of every person to live a full life. Energy and commerce can lead the way. We've plowed the hard ground with the bipartisan proposals in the Lower Cost, More Cheers Act to build unity, deliver results. President Biden signed 3 of these provisions already into law this year. President Trump signed 16 into law last Congress. Let's not let Speaker Pelosi's government price control scheme jeopardize the work to lower seniors' out-of-pocket costs. Let's do what's right for moms like Crystal, representing millions of moms, not just for hope, but for real life-saving solutions too. With that, I yield back.
The gentlewoman yields back. The chair reminds members that pursuant to committee rules, all members' written opening statements will be made part of the record. I now would like to introduce our witnesses. First, Ms. Therese Ball is a retired registered nurse from Ogden Dunes, Indiana. She's a multiple sclerosis patient and a Medicare beneficiary. Welcome and thank you for testifying today. Mr. Michael Carrier is a distinguished professor of law from Rutgers Law School, and we welcome you back to the subcommittee, Mr. Carrier. Thank you. Dr. Gaurav Gupta is the founder of Ascendant Biocapital. Welcome to the committee and thank you for being with us. Ms. Crystal Davis is a rare disease caregiver, a patient advocate, and the founding president of the Texas Rare Alliance. Welcome and thank you to you. And last but not least, Ms. Rachel Sachs. She's an associate professor of law at Washington University in St. Louis, and that is the School of Law. Welcome to you and thank you for being with us. So Ms. Ball, you're recognized for 5 minutes. Please remember to unmute. And thank you again for being willing to testify before our subcommittee today.
Chairwoman Ishu, Ranking Member Guthrie, and members of the committee, thank you for the opportunity to share my story. My name is Therese Ball, and I am a proud grandmother and retired registered nurse from Ogden Dunes, Indiana. I am here as a person living with multiple sclerosis, a Medicare beneficiary, and a patient advocate. I've dedicated my life to taking care of patients. Because of my nursing training, I've provided medical care and alleviated suffering for thousands of patients. But nursing school did not prepare me for the suffering I saw when my patients could not afford needed treatment. I had a front row seat to the horrifying reality of our drug pricing system. Drugs don't work if people can't afford them. I never thought I'd be one of those struggling patients until 2003, when I was diagnosed with MS and prescribed a medication called Copaxone. Let me tell you about Copaxone. The drug came to market in 1997 at a price of $769 a month. Today, that same monthly supply costs $7,114, almost 10 times higher. The drug company that makes it, Tivu, accomplished this by hiking the price 27 times over 2 decades. This pattern was not mirrored in other countries. By 2015, the price of Copaxone was on average 5 times higher in the United States than in other comparable nations. I faced these prices firsthand when I began taking Copaxone. It cost me $1,800 a month, and within a year, it completely wiped out my savings. It was devastating. Fortunately, I was able to find a grant from an independent charity, but I lived in fear that I might lose access. That day came in 2017 when the foundation did not renew my grant. At that point, Copaxone had increased in price to $6,000 a month. I was completely overwhelmed by this price tag, and no matter how many times I crunched the numbers, I couldn't make it work. So I made the terrifying decision to go without the drug. The health consequences were immediate and severe. I lost my memory and my quality of life suffered tremendously. My family began making preparations for when I no longer would be able to walk or live independently. Eventually, my doctor switched me to an infusion that I am fortunate to be able to afford through Medicare. But MS is a progressive disease, and I know I will continue to need different and likely very expensive medications. And one day I hope there will be a cure for MS, which is why I understand the importance of innovation. Drug companies have taken this idea of innovation, this hope, and turned it into an ultimatum for patients. They say we must let them charge whatever prices they want, or we can say farewell to future cures. But that's a false choice. Expert research has demonstrated that brand name drug companies could lose $1 trillion in sales over 10 years and still be the most profitable industry in the United States. Drug companies spend billions each year on TV ads and lobbying. They can more than afford to cut prices while maintaining their investment in research and development. We don't have to settle for a false choice. We can have more affordable drugs and meaningful innovation at the same time. Affordable drugs are more important now than ever. The COVID-19 pandemic has not just devastated the financial well-being of millions of people, it also continues to increase the number of people with chronic disease who will now rely on expensive medications. I know this because last year I had COVID-19. The infection was so destructive to my lung tissues that now I have to take an expensive inhaler called Brio, adding to my already steep monthly drug cost. Members of the committee, today you are considering a bill called H.R. 3. This bill would end the ban on Medicare negotiation and help beneficiaries like me by instituting a cap on what we pay out of pocket. In addition, the lower prices achieved through negotiation would be extended to everyone, regardless of what insurance they have. Today, you have an opportunity to bring relief to me and millions of other Americans struggling to afford our needed medications. As you consider this legislation, please remember our stories. I can't control my disease or change that I have MS, but telling you my story and advocating for lower drug prices is something I can control. Thank you, and I urge you to vote in support of H.R. 3. Patients have waited long enough.
Thank you, Ms. Ball, for being with us to tell your story. Mr. Carrier, thank you again for being with us. You're now recognized for your 5 minutes of testimony.
Great. Thank you so much, Chairwoman Eshoo, Ranking Member Guthrie, members of this subcommittee. Drug prices are too high, and one main reason why is that brand companies play all sorts of games to delay generic entry. Today, I'm going to focus my comments on two: pay-for-delay settlements and citizen petitions. This conduct makes no sense at all other than harming the generic, and if there were legislation that were passed, it would not affect innovation at all, but it would make consumers' lives better. My name is Michael Carrier. I'm a distinguished professor at Rutgers Law School, where I focus on the intersection of antitrust and intellectual property. I'm a co-author of the leading treatise in the field on antitrust and IP. I've written 130 articles on this, and I frequently file briefs with courts. So the first type of conduct that this subcommittee can address is pay-for-delay settlements. Sometimes a brand company pays a generic to stay off the market. Now, in 2013, the Supreme Court, in a case called FTC v. Activist, said that these settlements could have anti-competitive effects and could violate the antitrust laws. So after that decision, we saw that the number of pay-for-delay settlements went down. but there still are pay-for-delay settlements, and the parties still have every interest to muddy the waters, to raise arguments that were rejected in activists, and to try to continue to engage in these settlements. And so the legislation at issue here, HR 153 and HR 19, would address these real problems. First, it would allow the FTC to bring these cases in court. It's very hard when the brand company is paying the generic not in cash, but in these increasingly complicated deals for the FTC to figure that all out. So this takes years and years and costs millions of dollars in litigation. And so first, in order to give the FTC a chance to win this stuff in court before a decade or two goes by, the legislation would be incredibly helpful. And second, the legislation would fix some of these judicial mistakes. Sometimes courts don't apply activists the way that they were supposed to. Sometimes they fail to recognize a payment. Sometimes they say that entry before the end of the patent term is automatically okay, even though the Supreme Court explicitly rejected that argument in activists. And so the second reason why settlement legislation is so important is to fix some of these mistakes in the courts. So at the end of the day, I'm a big supporter of HR 153 and HR 19, which would make patients' lives better without touching innovation. Second, I'd like to talk about citizen petitions. Citizen petitions are designed to raise legitimate safety concerns with the FDA, but in reviewing every petition filed between 2001 and 2015, I found that most of these petitions actually are filed just to delay the generic. And the FDA actually denies most of these, 92% of them, 98% at the last minute. These petitions are filed just to delay generic competition. So what can this committee do? HR 2387, the Stop Games Act of 2019, would provide at least 4 benefits in stopping these frivolous citizen petitions. First, it would make sure that the FDA has a summary disposition power to get rid of these frivolous petitions without spending so much time on them. Technically, they have this power right now, but it is so difficult to satisfy that the FDA has never used the power at all. And so opening that up, as this legislation does, would be an excellent start. Second, it sheds light on what a primary purpose of delay is. When you look at all these petitions and you see the recurring themes of delayed petitions and repetitive petitions and ones filed at the last minute, you see a bunch of themes. And so if you take all of those facts and weave them into the primary purpose of delay, then that helps all parties in stopping this conduct. Third, there's a time limit. You can't find out about this petition and then wait for 5 years, as Mylan did with an EpiPen citizen petition. You have to file it within a finite period of time. And fourth, there's more information that the FDA needs to provide to Congress. So when you think about the fact that we don't know the petitions that are filed, how much delay actually happens from these petitions, more information into this black box would be incredibly helpful. So at the end of the day, the legislation on pay-for-delay settlements and citizen petitions would not touch innovation in the slightest, but it would make consumers' lives better. Thank you very much.
Thank you, Mr. Carrier. The chair is now pleased to recognize Dr. Gupta. Thank you for being with us. You are now recognized for your 5 minutes for your testimony.
Chairwoman Ashew, Ranking Member Guthrie, and members of the committee, thank you for the opportunity to testify today on HR 3 and the deleterious effect it would have on biopharma innovation and on patients. Let there be no doubt that we are living at the dawn of a golden age of therapeutic innovation. The first FDA approvals of oligonucleotide, bispecific, oncolytic virus, CAR-T, and AAV and lentiviral gene therapy all took place within the last decade. Novel small molecule drugs have cured thousands of Americans of hepatitis C, added decades to the lifespan of patients with cystic fibrosis, and positively impacted the lives of patients with sickle cell disease, while immunotherapies have transformed the lives of patients with cancer. Promising technologies such as targeted protein degradation and gene editing are perhaps not far behind. Future rewards will be greater still if we preserve our current system of incentivizing innovation. America is the global epicenter of accelerated drug development. 57% of all new medicines are invented by U.S. companies. The bulk of the remainder are developed by foreign companies in and for the U.S. market. An indirect benefit of this is that most novel therapeutics undergo clinical development and early commercial launch here in the U.S. The rest of the world understands that the American patient has earlier and broader access to groundbreaking therapies via these mechanisms. The scientific literature is unequivocal about the improved health outcomes generated from pharmaceutical purchasing. The 1.4% of GDP we currently spend on branded medications incentivizes future research and development and ensures that the global center of gravity of the pharma industry remains here in the US, where our citizens can enjoy the fruits of early access. On top of that, the biopharma industry's economic output in 2017 was estimated at 1.1 trillion, and the sector employed over 800,000 workers, 1/3 in key STEM occupations. It is undeniable that our healthcare system does not equally distribute innovations, with high out-of-pocket costs presenting barriers to medication access for many Americans. Insurance companies, pharmacies, and pharmacy benefit managers, PBMs, all sit between a medication and the patient who needs it. An incredibly confusing system of discounts and rebates obscures how much money goes to manufacturers and how much goes to middlemen. Actions to improve access to medications and reduce out-of-pocket costs for patients are long overdue. We can achieve these goals while preserving America's unique capacity for innovation. I'd like to contextualize pharmaceutical spending to other cost drivers in the healthcare system. The growth in overall national health expenditure is predominantly attributed to hospital spending. Branded drugs account for only 8% of the total. Our expenditure on prescription drugs encompasses not only what is paid to pharma companies, but also what is paid out of the system to middlemen. I would submit to the committee that a good faith effort to meaningfully curb healthcare spending demands addressing both the largest drivers, hospitals, and hidden costs, the prescription drug middlemen. In the context of prescription drugs, the very existence of out-of-pocket costs doesn't make sense. No patient gets a medication without a doctor prescribing it, and often insurance plans require that the doctor seek explicit prior authorization. It doesn't follow that insurance companies, having agreed that a patient needs a particular medicine based on FDA labeling for that product, then ask a patient to put skin in the game by paying a portion of the cost. They have skin in the game, their disease. Insurance reforms that cap or even eliminate out-of-pocket costs, not just in Medicare Part D, but also for Americans who receive coverage through their employers, through healthcare exchanges, and other types of health plans, would be a high-impact step towards ensuring broad access. The critical flaw of H.R. 3 is that it conflates drug prices and patient out-of-pocket costs. Importing foreign pricing would only marginally reduce what patients with high deductible plans, including Medicare, are forced to pay. It wouldn't solve their problem. What it would do is dramatically undermine the ability of American biotech companies to develop innovative medicines that could treat and cure innumerable diseases in the future. I'd like to conclude with a point about American competitiveness. The ability for parts of today's hearing to take place in person was made possible by the whirlwind development of vaccines and monoclonal antibodies for COVID-19. And this innovation capacity ought to be a source of national pride. My perception as a biotechnology professional is that other countries are eager to siphon our pharmaceutical prowess, particularly China, which has made biotech a strategic pillar. In 2016, the market capitalization of all Chinese biopharma companies was $1 billion. Only 5 years later, the combined market cap of all Chinese biopharma companies is north of $200 billion. In 2019, for the first time ever, a drug developed in China was approved by the US FDA. When I speak to Chinese biotechnology executives and Chinese physicians, they boast that they can run clinical trials faster than their US counterparts. The danger of HR 3 is that it will effectively drive biotech innovation to China. If we close off the market in the US, while China is opening their market to innovative new products, we will see companies launching impactful novel medicines in China based on clinical trials conducted in China. In order for patients to be able to buy American, we have to protect America's capacity to be a home for innovation. Let's continue to nurture this important work on our soil. Thank you.
The gentleman yields back, and we thank you for your testimony. The chair now recognizes Ms. Davis for your 5 minutes of testimony, and we thank you again for being with us.
Chairwoman Eschew, Ranking Member Guthrie, and distinguished members, I am privileged to be here today as a rare disease parent, caregiver, and patient advocate to share my perspective and represent the 1 in 10 Americans affected by more than 7,000 rare diseases. I founded Texas Rare Alliance to improve access and health outcomes for nearly 3 million Texas rare disease patients. That's a large number, and it's correct. More Americans have rare disease than HIV, heart disease, or stroke combined, and 95% of rare diseases lack an approved treatment. We know what happens to patients in other countries referenced by HR 3. They get worse access to treatments because the lives of people with rare diseases and disabled people are undervalued. In 2011, our newborn son lost nearly all movement at 2 weeks of age. At one point, my husband asked if I had shaken Hunter. I could never hurt our baby, but he was hurting. When doctors diagnosed our newborn with SMA, our world changed forever. SMA is like ALS in babies. It robs the ability to move, swallow, and ultimately breathe, and is the #1 genetic cause of death from infants. Doctors told us there was no treatment and no hope, but we couldn't afford to listen. The stakes were too high. With the help of a researcher, we manufactured a compound in the US and took it to Mexico for a trial. 8 weeks after his diagnosis, Hunter was the first SMA patient to receive a life-saving treatment. Nearly 5 years later, Hunter and his friend Ben started the Spinraza Expanded Access Program together. Soon after, the FDA approved Spinraza, the first SMA treatment. Upon FDA approval, insurers developed policies for Spinraza. Both Hunter and Ben were insured by United. Hunter met the Spinraza inclusion criteria. However, Ben failed to meet it because he depends on a machine to breathe for him. Ben's mom, Melissa, and I cried. She asked why Ben wasn't worth saving too. Ben was worth saving, but I couldn't change the policy. Biogen covered Ben in a patient assistance program until he secured a Medicaid waiver providing Spinraza. ICER evaluated Spinraza, scoring SMA patients a 0.2, determining its cost was not effective. We're already advocating against the use of ICER's QALYs. Adopting reference pricing that incorporates discriminatory QALYs undermines our advocacy efforts. We know CBO scored HR3, assuming the use of QALYs to set prices relied on by foreign countries. The NCD shared their concerns with the committee on HR3 and its implications for discrimination. At one point during the pandemic, we moved back to our St. Louis home after learning of QALY-based medical rationing in Austin. We knew St. Louis Children's Hospital valued Hunter and worked to save his life many times. This should provide some context for why I oppose HR3. The burden study by the Every Life Foundation found indirect and non-medical costs accounted for nearly 60% of the overall cost to rare disease families, with prescription medications accounting for only 10%. We can't expect to address affordability if we're focusing on such a small percentage of the problem. Rare disease parents work hard to keep our children alive. We become medical experts, providing a standard of care at home exceeding care at hospitals. That's not a smug statement. When our children are in the hospital, we don't leave their side. We know the standard of care for their rare disease, and we know if the hospital follows the protocol for a child of typical health, our children would be harmed and might not survive. We manage machines that feed, breathe for, or monitor our babies and children. We give them medicine and do their treatments. We don't get time off because the rare diseases our children fight against never take time off. Doctors tell us there's no hope, but we have more than hope. We have unconditional love for our children, and we refuse to give up on them. We value every breath they take, and we dare not take a single breath for granted. HR3 would also greatly reduce research and development of rare disease treatments. We don't see approvals coming from those countries. They're innovation deserts, a cruel place when you need innovative treatments to survive. Research and development are the stuff dreams are made of. We hold bake sales, runs, parties, and pretty much anything we can think of to fund research. The thing is, our funds only get researchers so far. Without follow-on funding from the NIH, biotech companies, or biopharmaceutical companies, the research stalls. At the current pace, it will take thousands of years to secure treatments for all rare diseases. Meanwhile, a third of children with rare disease will not survive to their 5th birthday. Research for rare diseases can move with the same relentless urgency as COVID-19 research. We must respect and value the lives of medically fragile, disabled, and elderly individuals. We cannot afford to stop opposing HR3. We refuse to save our children only to have a system adopt QALYs that give up on them. Thank you.
Thank you very much, Ms. Davis. The chair now recognizes Ms. Sachs for your 5 minutes for testimony, and thank you again for being with us.
Thank you. Chairwoman Eshoo, Ranking Member Guthrie, and other distinguished members of the Health Subcommittee of the House Committee on Energy and Commerce. My name is Rachel Sachs, and I'm an Associate Professor of Law at Washington University in St. Louis, where my research focuses on innovation and access to new pharmaceuticals. Thank you for the opportunity to testify before you today about the high prices of prescription drugs and how this committee might help solve these problems. My testimony will explain why comprehensive prescription drug pricing reform should include 3 types of policy solutions. First, reform should lower patients' out-of-pocket costs. Second, reform should fix misaligned incentives in our existing pharmaceutical pricing system. And third, reform should address the underlying problem of high drug prices. There is no single way to accomplish each of these three goals, and different countries have chosen different answers to each of them. But H.R. 3 pulls all three of these policy levers to lower drug prices. Other congressional proposals do not. Today, prescription drug prices in the United States are high and rising. Individual drug prices are rising. Between 2018 and 2019, pharmaceutical companies raised the list prices of half of all Part D drugs faster than inflation. System-wide spending is also rising. Between 2007 and 2017, Part D spending rose from $46.2 to $79.9 billion. Part B spending rose from $15.4 billion in 2009 to $35 billion in 2018. These dynamics create challenges for patients. About 1 in 4 people report difficulty affording their medications, and they may respond by rationing their medication or by delaying filling prescriptions. Patients have died as a result of these impossible choices. A large bipartisan majority of Americans believes that prescription drug costs are unreasonable. This committee has an important role to play in responding to the problem of high prescription drug prices in 3 key areas. First, limiting patients' out-of-pocket costs is necessary to relieve the financial pressures facing many patients. Today, there is no cap on Medicare Part D beneficiaries' out-of-pocket costs, and 1.1 million Part D beneficiaries have out-of-pocket spending above the catastrophic threshold. H.R. 3 addresses this problem by imposing a cap on Part D out-of-pocket costs. This committee might also consider additional policy reforms to accomplish this goal. For instance, as the National Academies has recommended, Congress might authorize CMS to limit patients' cost sharing for classes of drugs where treatment adherence can reduce total care costs. Proposals in this category would help millions of patients who have difficulty affording their medications. But lowering patients' out-of-pocket costs in isolation could even increase financial burdens on other patients and on Medicare. So these reforms ought to be paired with others which would directly address prescription drug prices. Second, our existing system for paying for prescription drugs creates incentives for actors to drive prices up rather than down over time. H.R. 3 includes 2 key elements to fix these misaligned incentives. It requires drug manufacturers who raise the prices of their drugs more rapidly than inflation to pay rebates back to Medicare, as Medicaid already requires. And its Part D benefit redesign gives both manufacturers and Part D plans greater incentives to manage price and formulary designs. There are many other examples of incentives this committee should consider addressing, including some of the often criticized business practices of pharmacy benefit managers. These attempts to address misaligned incentives are important, but they would not fundamentally address the underlying high prices of these drugs either. So third and finally, this committee should consider reforms that would strengthen Medicare's negotiating authority and increase the likelihood that our public payers can obtain fair prices for these products. H.R. 3 addresses this issue by providing the Secretary of HHS the authority to negotiate with the manufacturers of select high-priced drugs. To facilitate this negotiation, H.R. 3 uses international reference pricing, creating an average international market price across 6 countries as the basis for a target fair price in negotiations. There are many different ways of constructing an effective drug price negotiation system, and H.R. 3 offers just one potential example. Several of the countries included in H.R. 3's market basket provide examples of this and other approaches. This committee has the ability to help solve the problem of high drug prices, not only for patients, but also for our public payers. Chairwoman Eshoo, Ranking Member Guthrie, members of the committee, I'm appreciative of your focus on this important issue. I look forward to answering your questions.
Thank you very much for your testimony. And now we're going to move to member questions, and I will recognize myself for 5 minutes for mine. First, to Ms. Ball, thank you for being willing to share your story. It's a very powerful one, as well as your work as a registered nurse. In your testimony, you said that the MS drug Copaxone went from costing you $1,800 a month to $6,000 a month. Was there any innovation that changed that drug between 2003 and 2017 to account for the price change?
No, actually, there was no innovation. What had happened was they raised the price 27 times, but what they did was they had a new one brought out in 2014. So you usually with Copaxone, you do 7 injections, right? 1 a day. They brought a new one out that was the 40 milligram. And what it did was it made it easier. You only did it 3 times a day. So,
I see.
you know,
Mhm.
it
Right.
sold it to the physicians and to the others.
Right. Were there, excuse me, were there other countries that saw comparable price hikes to that drug during that time? Do you know?
Yes, but they pay less than we do, even with that, because they
see.
negotiate all their drugs. So
Is Copaxone your only option? Does it have any market competition?
it really doesn't. The only thing it had is that when it came up to do the 40 milligrams, they were starting to lose their abilities to, you know, patent it and everything. So that's why they redid it. It did not change anything. There was no evidence that it improved.
Okay.
And it also
thank you. Dr. Gupta, thank you again for being with us today. I'd like to ask you the following question. You've heard Ms. Ball's story. It's a powerful one. It covers a range of issues relative to pricing, a drug that has no competition, the price hikes over X number of years, and how that has impacted her life. It's a story of many people in our country. Specifically, what can you say to her? I mean, you hold your view, which I respect, but what would you say to Ms. Ball? What do you have to offer to her?
Thank you, Congresswoman. And Ms. Ball, I was moved by your story, of course. You know, I'm a physician as well as a biotechnology investor, and I can assure you that, you know, having moved, you know, over to the biotechnology industry, I'm impressed every day with the passion and the tenacity of the folks in our industry and their commitment to patients first and foremost. And at the core of everything we do, we know patients are waiting. And that's why it's frustrating when patients don't have access to drugs. And you know, Ms. Ball, from my understanding, you know, the out-of-pocket costs were particularly a barrier for you. And I think that, you know, from our perspective, we agree there. I mean, you know, the data is unequivocal. It's just a $10 increase in out-of-pocket cost by insurers has been shown to increase mortality by 33% for some patients. And these are easy fixes. You know, I would say that we can find common ground and make it easier to access medications for all patients.
Okay, we all have limited time, and I appreciate your directing some of your comments to her. To Ms. Sachs, as a lawyer, are there any provisions in HR 3 that would keep Medicare from continuing to cover all the drugs that it does today? And are there any provisions, in your view, in HR 3 that would limit patient choices?
Thank you for the question. This is such an important one. And as you know, access is at the heart of HR 3. By making it easier for patients to afford their medications, it will increase access to them. And nothing in HR 3 disrupts any of Medicare's requirements to cover drugs, including in the 6 protected classes. I also want to make a very brief clarification about what we mean when we talk about access. What we mean is that a pharmaceutical company would rather pull their drug from the American market than charge us the same prices or even a premium that they're already charging in other countries and at which we know they make a profit. So when we talk about access, we're talking about choices that the pharmaceutical company is making, not Medicare.
Thank you. I think my time has just about expired. And a reminder to all of the witnesses that members will have the opportunity to submit questions to each one of you, our written questions, and we ask that you respond and answer them in a reasonable time frame. So the chair will now recognize. Let's see. I think that I'm going to recognize, per our agreement, Mr. Guthrie, to recognize Mr. McKinley. And welcome to the subcommittee, Mr. McKinley. And you have 5 minutes to ask your questions. And we hope and pray that your wife's surgery, that's my understanding, goes well.
Thank you, Anna, and thank you for the opportunity, this chance for you to give me that chance to get back to the hospital, be with her, and for ranking Guthrie. I appreciate it. Look, we all know there's a need for drug pricing reform. I don't think there's any one of us would be arguing against that, but pursuing this highly partisan HR 3 is just an example of overreach, unfortunate overreach that occurs too often in Washington, and it gets in the way. All the political observers that I've read about in Washington in the press are saying that HR 3 is not going to pass the Senate. So I've got to say, fundamentally, why are we doing this? Why aren't we working together to try to pass something that can be signed into law? There are bipartisan solutions that were included in HR 19. So unless we change the course, this projection of this legislation, we know how the story is going to pan out. We've seen it before in immigration. We're about to see it in the infrastructure bill again, overreach on that, and we're seeing it now in this drug pricing. These are all bipartisan issues that we would all work together on if we focused on what we need to get done. Focus on those, but that's not what's happening with this. Look, we were here to get solutions to it, and I really want to get to it. HR 3, unfortunately, is an overreach, and unfortunately, it gives me the impression for those in the public that Congress is seemingly willing to let American patients suffer. This is a high-stakes political game we're into right now, and if the Senate doesn't pass it and it doesn't get to the president's desk for signature, the American public is going to suffer. I think they deserve better. HR 19 includes caps for insulin deductibles. It passes on rebates directly to state Medicaid programs, ensuring that PBMs do not profit off government programs. And it makes it unlawful for pay-for-delay practices whereby drug companies enter agreements with generics and biosimilar manufacturers to delay a competing drug coming to market. These are all obvious. These are just a sampling of the 40 bipartisan bills that we already passed out of our committee. So we know that the loser here is going to be the American public if we don't get a bill to the president's desk for signature. So my question is now, we know that utilizing generic medication is one of the best ways to lower drug pricing. But PBMs and Part D program plans are not covering generics. So, and this practice costs seniors $4 billion. Insurance gets $4 billion annually. So, Ms. Sachs, in your testimony, you discussed some of these issues about the formulary design in Part D. The current system incentivizes placement of higher cost drug brand prices over generics. And the bill that I'm working with Kuster about, 2846, addresses this issue by ensuring would lower the price. Can you speak more to this issue of formulary design and how the current trend is leading to increased costs for patients rather than lowering?
Yes, absolutely. So without going too far into the details of the Part D benefit design, as this committee is well aware, the current incentives, unfortunately, may lead both manufacturers and PBMs and plans to increase or drive up prices over time rather than to reduce them. And so the Part D redesign elements in HR 3 and also in HR 19 are important for minimizing some of those incentives. However, they only work where there are generic or biosimilar opportunities available for patients. And in many of these cases, there are not. So in my testimony, I also give the example of a drug like Humira, which was first approved in 2002 and has lively biosimilar competition in Europe, but where we still have no competition today and won't for another 2 years. Yet it's one of the top 10 selling drugs in Part D. The idea that we would negotiate the price of a drug like Humira and be able to obtain better prices for patients and our payers is at the heart of HR 3, but it's not part of HR 19.
If I could get back, I want to ask a last question to Dr. Gupta, because the United States, we're still across this country still experiencing a wave of drug overdoses at a higher rate than we've ever seen before. So my question, Doctor, is how would HR 3 affect the price and discovery of new non-addictive pain medication and treatment medically assisted treatments? How would HR 3 affect that? Can you share some of your thoughts?
Thank you, Congressman. Yes. So I think the need for developing non-opiate, non-addicting pain medications is one that the entire biopharma industry is working hard to tackle. You know, we're aware of both the need for treating pain, but also the need of creating alternatives to opiates. It's early stages still. There's several things in development that we don't know if they're going to work yet. And I would caution that price controls, which, by the way, don't ensure that we'll be passing savings directly onto patients, would really put a lot of that work at risk.
Okay, thank you. My time's expired, and I just want to say to Anna and Brett, thank you. I want to be with my wife. So God bless.
Absolutely, and we want you to, Mr. McKinley. I will keep her in my prayers. Thank you. Godspeed. The chair now recognizes the chairman of the full committee, Mr. Pallone, for your 5 minutes of questions.
Thank you, Chairwoman Eshoo. I'm going to get right to a question to Ms. Ball, and then I'm going to try to get a few into Professor Sachs. So I'm trying to ask you if you can, limit your remarks. Ms. Ball, can you tell this committee in your words why Congress must take action to give Medicare the power to negotiate drug prices, and why this task is so urgent, and how it will make an impact on the lives of individuals like yourselves who are struggling with the high cost of prescription drugs?
Yes, thank you for asking. The questions you have asked is how it would help me. It would help me because when you lower the price of the drugs, then it is more affordable to people, and they will be able to get the drugs without the HR 3 that not only takes care of lowering the drug prices is most important, because even though the cap is at 2,000, we have right now a Part D drug is 15,000. So if we can do both, reduce the medication prices and also maintain the cap, it's going to help us 100%. There's too many people going without because of the fact that it's so expensive.
Thank you. Now, I think we all recognize that we must act and we have to acknowledge it all, but we should also acknowledge that not all drug pricing legislation is the same and not all policies are equally effective. There are a number of proposals we're considering today that do not include the goal of negotiating prices or the inflation rebate that's in HR 3. And I strongly believe that we need to act immediately on HR 3 because it offers a comprehensive approach. So let me go to Professor Sachs. 3 questions. As you briefly mentioned in your testimony, can you discuss why reforming the Part D benefit and capping out-of-pocket costs in Part D, while critical in conjunction with other policies, on its own is not sufficient to actually reduce prices?
Yes. So although capping out-of-pocket costs is important to help patients, it doesn't actually lower prices or spending. It just moves money around in the system. MedPAC projected that lowering patients' out-of-pocket costs could even increase overall premiums a little bit and increase Medicare spending as subsidy for those premiums. So although it's important to reduce out-of-pocket costs, that needs to be coupled with other reforms which would directly address those high prices.
And can you explain how the different titles of HR 3 work in tandem, and why, in order to effectively lower prices, we have to use more than one approach to deliver real savings?
Yes. So the restructuring of the Part D benefit is critical to help seniors afford the cost of their prescription drugs. But because it just moves money around in the system, the other titles are also important. So the inflationary rebate provisions as a pillar of HR 3 extend to Medicare a strategy that's worked well in Medicaid to control price increases in that program and should discourage companies from raising the prices of their drugs, as we've heard about with Copaxone. But even that won't fundamentally address the underlying high prices of these drugs or the government's lack of negotiating leverage. And that's where the negotiation element of HR 3 comes in. So particularly for specialty drugs with little or no competition, HR 3 strengthens Medicare's negotiating authority and enables our public payers to obtain more fair prices for these products.
And then lastly, my understanding is that HR 19, this is the Republican alternative that we're considering today, does not establish a negotiation framework, nor does it contain the inflation rebate provisions that are included in HR 3. Given that, is HR 19 effective at reducing drug prices? And if not, why not?
That's a correct description of HR 19, precisely because HR 19 is centered around only the restructuring of the Part D benefit. It's unlikely to save our system very much money. So it would certainly help seniors with their out-of-pocket costs, but it has no answer for the company who raises the prices of Copaxone. I believe we heard 27 times in a decade, from 700 to 7,000. That would not be addressed in something like HR 19, and it might even increase premiums for seniors and government spending overall.
All right, thank you very much. Thank you, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the ranking member of our subcommittee, Mr. Guthrie, for your 5 minutes of questions.
Thank you, Madam Chair. I really appreciate it, and this is a very valuable hearing. I think we're seeing there's a lot that we agree on. I agree with a lot of what almost all of what Professor Carey said, a lot of what Professor Sachs has said. We want to put together real answers and maybe answer the president's call. Let's pass what we can agree on. And I will agree with what Mrs. Ball said. And I think Chair Daggett and I, when I was in O&I, looked at insulin. We have long existing therapeutics that increase faster than inflation, and that's something I think we need to look at why that's moving forward. And I think the number one is to get competitors into the marketplace. And matter of fact, last week I think Representative Schrader was in the Oval Office. I was in Kentucky getting a bill signed about dealing with patents and the way that people gain patents. So there are ways to move forward with this. You know, we're talking about negotiation, and the way this bill's kind of structured is more price setting. That's our concern, not just negotiating. It's the way the price setting mechanism looks forward. And I think it was quoted that 93% of the people support negotiating or essentially lower drug prices. But I've seen similar polling to say if you ask at the expense of access to life-saving therapeutics, that drops. And I can't imagine what it would be if savings in Medicare would be used as a pay for some other type of issues. But the assumption in HR 3 to me is you can change this. I'm going to get to Dr. Gupta. You can change how you pay for a product without changing what you receive and what you get. And that's the concern. You know, President Biden in the joint session kept talking about foreign payments and the way foreign payment drugs are moving forward. I think COVID-19 is a good example. Dr. Gupta, Europe decided they want to negotiate for a COVID vaccine up front before, and we went the opposite. We said we're going to invest in pharmaceutical companies working together to bring a vaccine forward, and we know the results. Europe is currently, unfortunately, very unfortunate for our allies, in a lockdown where we're in Kentucky. You could get one today if you wanted a vaccine. So, Mr. Gupta, would you talk about what Europe did and how that's an example of what HR 3, if we're going to import European-style drug pricing, how that could change what results we get?
Absolutely. Thank you, Congressman. So we see on our side is that other countries seem to be willing to deny this is particularly acute in the setting of, as illustrated by COVID vaccines, but also as we see routinely with cancer medications, where there's significant delays that sometimes border on years to deliver groundbreaking cancer medications to patients, in an even more extreme example. And I think those are also examples we should look at as the kind of risk that would be entailed here if we were to have price controls as per HR 3.
price the way they price in my opinion, without having the results that they receive. Dr. Deeks in our long haul COVID hearing quote, and I quote him, he talked about how we're going to have innovative therapies for long COVID. And he said, quote, developing therapies will not happen unless we somehow find a way to incentivize our partners in the pharmaceutical industry, unquote. And so what we're looking for innovative therapies, and we need to deal with situations like Ms. Ball, absolutely. But we don't need to affect the young children with SMA, and that's what we want to move forward. Also, Dr. Gupta, I want to touch on value-based agreements. These are arrangements that a new reimbursement method where manufacturers are paid if their drug works, and if it doesn't work as intended, they return payments via refunds or rebates. Representative Schrader and Representative Mullen and I are working on a bill for these two arrangements. Could you talk about value-based agreements and how that could affect drug pricing?
Yes, thank you. I think that is a promising avenue to explore. On an individual company and medicine basis, which is to say, sort of a voluntary basis, I think it makes sense for companies to put together those kinds of creative price proposals. And I think we should explore to sort of better understand the potential impact and how those could improve access.
I'm a big believer in the Medicare Part D that we do need to get smoothing so people don't have to pay everything up front in January when their new deductible moves forward, and also cap out-of-pocket expenses. But right, if you're just subsidizing a rising drug price marketplace, it does moves money around, as Dr. Sachs said. So I think we need to do work to do patent reform, as Representative Schrader and I have worked on already, to make sure that we get competition into the marketplace as soon as possible. Protect patents for innovation, but bring competition as soon as possible. And Madam Chair, my time has expired. Thank you for having this hearing.
The gentleman yields back. The chair is pleased to recognize the gentleman from North Carolina, Mr. Butterfield, for your 5 minutes of questions.
Thank you, Madam Chair, and good morning to you. It is still morning here on the East Coast. No, it's not. No, it's not. It's after 12 noon, but thank you. It's still morning on the West Coast, but we're past that noon mark here in Washington. But thank you for convening this most important hearing today. Madam Chair, we've talked about drug pricing on this committee now for years, and it's time for action. I could guarantee passage if my Republican friends will just work with us, not just throw one-liners at us, but just work with us. We can get this done. We can get it done in this session of Congress. And so thank you for the hearing today, and thank you to our witnesses. Let me begin with Professor Sachs. Thank you for your testimony. During my time in Congress, I've heard from countless constituents who say they cannot afford their prescription medications. We all hear it when we go home. It isn't right that someone in our country should have to choose between food and medicine. It's just not right. It isn't right that 1 in 3 U.S. adult patients forego desperately needed medications because of cost. In my home state of North Carolina, including right there in my district, we are the home to many biotech and pharmaceutical manufacturers, and I believe that innovation by these companies should be encouraged. But clearly the American people are suffering, and we all know that. The status quo is not acceptable. Congress must act to ensure that the American people have access to and can afford the treatments that they need. And so all of that to say, Professor Sachs, H.R. 3 creates a new $2,000 out-of-pocket cap on Part D spending. I think you would agree that this new limit would be welcome news to millions of beneficiaries. Now, you explained a few minutes ago, if I heard it correctly, to Chairman Pallone, that an out-of-pocket cap cannot lower drug costs on its own. I think you said that. How will the other pieces of H.R. 3 lower costs for seniors?
Thank you, Congressman. This is an important distinction. H.R. 3 recognizes that reducing patients' out-of-pocket costs is critical, but on its own, that's not the same thing as reducing drug prices. It covers those up. It actually makes it harder to see that a company is raising its prices 27 times, as we heard from Ms. Ball. So it's important to lower patients' out-of-pocket costs, and that $2,000 cap would be a huge help to many Medicare beneficiaries. But it's important to also use the other elements of HR 3 to discourage companies from increasing their prices as fast as we've heard them do already in this hearing, and I'm sure we'll hear more about it later as well. And it's important to use the negotiating elements of HR 3 to really make sure that the government has a strong hand in bargaining for the prices of these products when we're paying many times more than comparable countries for the very same drugs.
Precisely, and thank you so much for that. Let's talk for a minute or two about rare diseases. You may know that I am the co-chair of the Rare Disease Caucus here in the House. Over 95% of rare diseases, people don't realize this, over 95% of rare diseases do not have any treatment at all. Many, like sickle cell, which predominantly affects African Americans, are chronically overlooked and underfunded. We must foster the creation of cures for these conditions. Ms. Sachs, you discussed in your testimony various ways that HR 3 could impact future drug development. Do you anticipate a large impact on first-in-class products for rare diseases like sickle cell?
I do not, and here's the reason why. Most rare disease drugs won't qualify for negotiations under HR 3 because only the top 125 drugs under Medicare Part D and the top 125 drugs more generally are even eligible for negotiations. And so for the top selling drugs in Medicare, we're often talking about drugs that hundreds of thousands of Medicare Part D patients are taking, to say nothing of patients outside of Medicare. But by definition, orphan drugs are treating very small populations of patients, and it's very difficult for them to become top spend drugs of the type that would even qualify for negotiations. I also do know that there has been bipartisan interest in Congress in the last few years of looking at when companies might be abusing the Orphan Drug Act, such as to extend their monopolies by stacking orphan drug exclusivity periods. So it's possible that there might need to be some attention to those concerns, but it's very unlikely that rare disease drugs would be under the negotiating scope of HR 3. Not never, but unlikely.
Thank you so very much. I'll end with the last statement, the first statement that I made during my remarks. 95% of rare diseases do not have a treatment. Colleagues, let's redouble our efforts. Thank you, Madam Chair. I yield back.
The gentleman yields back, and we thank him. The chair is pleased to recognize the ranking member of the full committee, Ms. Kathy McMorris Rogers.
Thank you, Madam Chair. And just let me say, we're anxious to go to work to focus on cures and for those with rare diseases and beyond. I am committed, Republicans are committed to addressing how we bring down the cost of prescription drugs. It is a priority issue. Anxious to work with Republicans and Democrats on solutions. We can build on right to try. We can continue to expand the generics. Transparency, accountability for PBMs is priority. I'm very concerned, though, about the current approach and the impact that it's going to have on innovations in curing diseases from a very big picture. So I wanted to start with Dr. Gupta and just thank you again for joining us, bringing your expertise and experience. You spoke about us living at the dawn of a golden age of innovation. And it is one of those times that we should just be focusing on how we continue to lead in ways that are going to result in life-saving, life-changing therapies and treatments. I would like to ask you, what are you most excited about? And put in layman's terms, what it means for patients and families across the country, and if you have any concerns about the proposal before this committee this morning.
Thank you, Congresswoman. What I'm most excited about is, several years ago, we used to have a concept in our industry of targets that were called undruggable, which meant that with the toolkit that we had to develop medicines, we simply couldn't hit them. We knew, where the disease was coming from, but we couldn't do anything about it. Increasingly, that word is leaving our vocabulary, and I think that is the most exciting, development. When I say we're at the dawn of a golden age, I really believe that. And as you said, Congressman, I think we should pour gasoline on the fire rather than trying to snuff it out.
Yes, thank you for that. Ms. Davis, I wanted to thank you for joining us today and sharing your story. As a mom, I'm always amazed and inspired by others, and especially all that you have done for your son Hunter and fighting for him. You basically took a never say no attitude, and that determination is one that we all admire. I appreciated you highlighting the miracle drug that has now been made available to those with SMA. And as we just heard from Dr. Gupta, you know, the concern is that proposals like HR 3 are going to disrupt the path to those breakthroughs for the next generation of children like Hunter. As you know, the SMA treatment became more widely available in the US in February of 2017, but sadly it wasn't made available in Australia until 11 months later, or 6 months later in Canada, 4 months later in France, 5 months later in Germany, 6 months later in Japan, 6 months later in UK. The bill we're discussing today would import into the US the pricing schemes from those countries who didn't have the kind of drug that Hunter needed available until much later. So what would you tell the members of this committee about what the extra 4, 5, 6, or 11 months without this treatment would have meant for you and Hunter?
So for SMA, every day matters. Sometimes every minute matters. Once motor neurons are lost, we can't get them back. And so what it would mean is more babies and children would be permanently disabled and more lives would be lost. And that is something we cannot afford to allow happen. In fact, we really need to be working for pre-symptomatic diagnosis and treatment, not only for SMA, but all of these childhood conditions.
Thank you very much. And I also wanted to ask if you would just speak to the way that other countries define the value of a life and how that impacts the availability and also potentially the price of drugs.
Yes, it's based on the quality metrics, and it's used by discounting the value of the patient's life based on how chronically ill or disabled they are, and then multiplying that by the number of years that they anticipate the survival. And so it's a very discriminatory practice, and it's something that we have acted vigorously to prevent from happening in the US, as we've done with ICER. We prevented CVS Caremark from importing ICER's quality metrics, and we also opposed the ventilator medical rationing during COVID using those measures as well.
Yes. Thank you for joining us and speaking out. My time has expired. I yield back.
The gentlewoman yields back. Chair is pleased to recognize the gentlewoman from California, Ms. Matsui, for your 5 minutes of questions. Great to see you, Doris.
You too, Ann, and everybody else, and thank you very much, Madam Chair, for calling this hearing. It's so important. Thank you for the witnesses for being here. It's important to hear about your experiences and your expertise. I know there's been a lot of conversation on the out-of-pocket cap in Part D, and I've listened to Professor Sachs and understand that this is just one tool, but particularly for beneficiaries as they have challenging prescription drug costs is really very, very important. So just a comment, Ms. Ball, can you share what let's say a $2,000 out-of-pocket maximum in your Part D plan would mean for you? Would this provide you with better certainty for your total drug costs for the year? Ms. Ball, are you present? Okay, let me go on here.
I had trouble with unmuting. I'm so sorry. Yes, how it would have benefit me is that I would be able to know exactly what I would need if my pricing went up to 2,000. But basically what happens is that I would have the ability to receive my drugs, which is the most important part, because at the time that it went to $6,000, there was no way that I could have. And that really was devastating to my health and to my family. So it would help in a great deal. I'm sorry, we can't hear you, ma'am.
Doris, you need to unmute.
Sorry about that. I got unmuted. I want to talk about the role of rebates. Reforms like the inflationary rebates in HR3 will realign the incentives manufacturers have for raising their prices, but may be limited in their ability to assist Medicare in obtaining lower prices, particularly on specialty drugs. A similar problem exists with rebates that drug manufacturers pay to PBMs and insurers. Typically, these post-sale rebates or discounts are not available for drugs that lack competition. Professor Sachs, for expensive drugs that have no manufacturer rebates, what leverage do Part D plans and PBMs currently have to negotiate lower prices?
They have little to no leverage today.
Okay. Professor Sachs, inflationary rebates can address the overall growth of a drug's price over time. But what other mechanisms are needed to reduce costs, particularly for specialty drugs with an initially high list price?
Exactly as you just said, the inflationary rebates will be important to discourage or prevent drug companies from hiking the list prices of their drugs more quickly than inflation. But for companies that set a high price in the first place, especially where that price is many times what our other countries are paying for the same drugs, HR3 gives the Secretary the authority to negotiate for the prices of those drugs and strengthens their hand in that negotiating process.
Okay, thank you. I want to go back to, we're talking about out-of-pocket caps. Professor Sachs, can you briefly describe how HR3's proposal to cap out-of-pocket costs compares to HR 19 that we are also considering today?
Yes, so the ideas are very similar to help patients afford their out-of-pocket costs, but the details are different in two important ways. So first, HR3 is more protective of patients. It imposes a $2,000 annual limit on patients' out-of-pocket costs rather than a $3,100 out-of-pocket limit on patients' out-of-pocket costs. And then second, HR 19 imposes less responsibility on manufacturers in the catastrophic phase, only 20% compared to 30% in HR3, which will help manufacturers be discouraged from driving patients into that phase of their benefits.
Okay, fine. Thank you, Madam Chair, and I yield back my time.
The gentlewoman yields back. Pleasure to recognize the former chairman of the full committee and the Republican lead author of the CARES of the what's the matter with me?
21st Century
the 21st Century Cures Act. I just had a blank moment there. Mr. Upton, you're recognized for your 5 minutes of questions. Great to see you.
Well, it is. Thank you, Madam Chair, and thanks for bearing with me a little bit. We had a little issue with WebEx getting access to it. So anyway, and we all hope that I already heard from Dave McKinley that his wife Mary does well with this surgery this afternoon. You know, a couple things. You know, it's no secret that all of us on this committee have been very involved in health research, and obviously 21st Century Cures is a major milestone for us when we passed it back in 2016. President Obama signed into law. For me, doubling the money for the NIH back in the 90s, working with Henry Waxman and John McCain, my good buddy, which was successful, and obviously now so we're beginning to work on Cures 2.0. SU, myself, and others very involved in that, as well as Pallone and leadership on both sides. I just want to thank Ms. Davis. You know, just a touching story for me and many on the committee that were back on the committee back in 2015. They saw two of my constituents, two little beautiful girls, broken. We actually call them Sleeping Beauty and Cinderella from my district, who were impacted with SMA and just so excited about the progress that's being made. But that's the case with every rare disease. So cystic fibrosis, all of them. We all want cures for these, and we really want to get to the point where we can be the lifeline for those families. You know, in one of the things that also drove us to get 21st Century Cures done was that we realized that venture capital was leaving our country. It dropped by 50% back in the early part of the 2010s, early part of that decade, going overseas because we weren't the leader in innovation. We weren't the leader in getting these drugs approved. And I have a fear that countries like China and India, they haven't explicitly stated that they want to become global leaders in medical innovation yet, although they're trying. But it's often those manufacturers that often seem to be cited the most in terms of tainted drugs, quality manufacturing issues, and the policies of HR3 could in fact make those countries potentially more attractive for R&D and manufacturing investments than the U.S. So Dr. Gupta, we want to take the chance that we could lose U.S. global leadership in this space, end up with fewer new medicines, potentially longer delays in access to new medicines in the regulatory systems, which may not have the same gold standard that we have here in the U.S.
Thank you, Congressman. And I think you've outlined precisely the risk that we face under some of the provisions of H.R. 3. China is signaling to its companies it wants them to catch up and that they can charge relatively high prices in China. It's expensive to run a clinical drug trial to the FDA standard, and I think you've outlined precisely what we may see if that would happen.
You know, one of the things, too, is I hear colleagues on both sides talk about where we are. We all want lower drug prices, that's for sure. We went sort of through the same argument last year by saying we have a bill, H.R. 19, it was actually bipartisan, was made up of bipartisan bills. Every one of them had Democratic and Republican support that we packaged together. And H.R. 3, we said, isn't going to get to the finish line, and exactly that same thing happened. And that's the fear, again, in this Congress, that H.R. 3, the way that it's designed now, same bill as last year, isn't going to get to the president's desk, whether it be a Republican or a Democrat. So why not take what we know we can agree on and move that, at least even do it first, rather than wait for H.R. 3. But I guess in my last minute, I just want to say one of the provisions in the cures that was signed into law was the Precision Medicine Initiative at the NIH. And many new innovative therapies are highly targeted, underscoring the importance of patients having access to a range of treatment options. The future of precision medicine and highly effective therapies is not, for sure, a one-size-fits-all. That approach is at odds with how the drug pricing proposal would set prices for medicines, determining a single price based on the price that we pay for medicines in other countries and population-level comparative effectiveness research. Neither of these factors, as I understand it, will account for the value of those treatments to an individual patient. So are there any recognitions for personalized medicines included in the price setting in H.R. 3, Dr. Gupta, in my last 2 seconds?
Thank you, Congressman. I'll be brief. Personally, I'm actually unfamiliar with any provisions that might cover that. I'll have to review that and get back to the committee. Thank you.
Okay, I look forward to it. With that, Madam Chair, I yield back my balance of my time.
The gentleman yields back, and it's a pleasure to recognize the gentlewoman from Florida, wonderful member of our committee, Ms. Castor, for your 5 minutes of questions.
Well, thank you very much, Chairwoman Eshoo. Thank you for your leadership here. This is a very important hearing on legislation to lower the cost of prescription drugs. So thank you for calling us all together, and thank you for the testimony of our witnesses as well. I mean, I encourage everyone to go back to the memo that summarizes the reason that we're here. I mean, drug prices in the United States continue to soar. The RAND study was cited in that summary memo. Americans pay 256% more for their prescription drugs than the average 32 countries. And when you're talking about brand name drugs, it's more than that, 344% more. That's outrageous. And it's exacting a toll on families, all of our neighbors, and it sure impacts the federal budget and the bottom line because of our extensive outlays for Medicare and Medicare Part D. This just doesn't make sense anymore that there is a prohibition on Medicare negotiating prices. And I want to give a shout out to our colleague, Peter Welch, who has spent a good bit of his time in Congress fighting for this. And I think Peter, Representative Welch, I think this is our year that we're going to get it done. And I really invite our Republican colleagues to join us on this to lift that prohibition on negotiating drug prices. If we do it in the VA, it works. And it's really anti-American, isn't it, that we would prohibit anyone from negotiating something in America. But I'd like to spend, Professor Sachs, a little time with you to talk about generic alternative and sole source drugs that don't have the market forces to drive the price down. We've seen in the current market, we don't have the tools to restrain those costs. Will you describe for us the way that drug makers often determine a price for sole source products? Is it fair to say that there isn't a lot of leverage for employers or insurance companies to control costs for these drugs, short of excluding coverage that we don't want to do?
Thank you. So as to your question of how companies determine prices for these drugs, it is very common to hear that drug companies, they charge what the market will bear. They're not looking just to recoup their R&D investments. They're looking at other drugs, they're looking at services and benchmarking their prices accordingly. And you're also right to suggest that there isn't a lot of leverage for employers or insurers to control costs for those drugs, but I don't think it's necessarily the case that exclusion or the threat of exclusion is necessary. And so for an example here, I think we could look to Medicaid. Medicaid is required by law to cover essentially all FDA-approved drugs, but in exchange, it's entitled to preferred pricing benefits, including inflationary rebates of the type we're considering today, and different governmental reports have shown that those inflationary rebates are very effective in helping Medicaid get much better prices than Medicare Part D for the same products.
So given this, you appear to agree that it makes sense to give the Secretary of HHS the power to negotiate prices of certain high-priced drugs, that the lack of competition and that where we have a lack of competition and our neighbors are forced to choose between taking their medications or eating or paying for a roof over their heads. Is that right?
Yes. Unfortunately, too often, as I mentioned, it's 1 in 4, almost 1 in 4 Americans, 24%, including 23% of seniors who have difficulty affording these medications.
So some of the bills today do address the issue of generic competition by addressing some of the major barriers to effective, timely generic entry. These policies are crucial to making markets for prescription drugs work more effectively. However, why is it not enough on its own? Why must we also pass a comprehensive solution like what is contained in H.R. 3 in order to meaningfully bring down drug prices for all Americans?
Yes, this is such an important question, and these bills promoting generic competition are important. I don't want to suggest that Congress shouldn't pass them, but they are reactive. So as we heard from Professor Carrier's testimony, pharmaceutical firms have been engaging in pay-for-delay deals, citizen petitions. Product hopping is another example of this for years. And if Congress is now able to crack down on those, industry will develop innovative new ways to extend their monopolies. A comprehensive negotiating strategy would limit, although probably not completely avoid, the need to play this kind of whack-a-mole with pharmaceutical company gaming tactics in the first place.
I agree. I think H.R. 3 is a very important comprehensive approach to controlling drug prices for all of our neighbors. So thank you, Chairwoman Eshoo, for having this hearing, and I yield back my time.
The gentlewoman yields back. It's a pleasure to recognize Dr. Burgess for your 5 minutes of questions.
I thank the chair, and just like in the last Congress, this hearing has been very instructional, and certainly I have enjoyed the testimony of our witnesses. Dr. Gupta, if I could ask you, I think we'd all acknowledge that the National Institute of Health is a national treasure, and it has contributed mightily to the basic research and understanding of many diseases. But it doesn't seem to me like the agency was designed with the development of bringing new drugs to market in mind. So could you elaborate on that a little bit, the process of bringing a new drug to market? and the process, for example, in scaling up the coronavirus vaccine?
Yes, thank you. Thank you, Congressman. I think that's a very important point. And the NIH is a fabulous organization, world class, but it's not a drug development organization. And the core skill set of biotech and pharma companies is developing medicines, getting them, manufacturing them, running them through clinical trials, interfacing with the regulators, and then, of course, actually selling them. There is no glide path to market a drug once it's approved. There's no national formulary. And it is actually, and I think big companies are better than small companies, it's actually important to have the ability to make sure that physicians and patients can get them and are aware of them. And the NIH is not equipped to take the prototypes that they sometimes build or the scientific ideas they sometimes generate all the way through that lengthy process.
Right. When Zika was a concern several years ago, and multiple meetings with Dr. Fauci out at NIH on this topic, and he did point out that they have a small manufacturing capacity at NIH, but I would underscore small, and nothing of the sort that would have permitted the rapid introduction of the coronavirus vaccine, for example. That did require the involvement of the private sector, and I think we're all grateful that involvement occurred. So, Dr. Gupta, stay with you for a minute. You actually have some experience in the business world. You've probably been a part of negotiations yourself from time to time. The excise tax, as enumerated in HR 3, does that look like a negotiation process to you?
Thank you. I think that that mechanism would provide a lot of leverage to a party that would disadvantage greatly, the counterparty there.
Well, and again, you also understand, investment of capital is a lot of things, and a lot of them are good things, but capital is generally not known for being courageous. And so if capital is challenged in one location, what's likely to happen?
Well, thank you. I appreciate the chance to comment on this as well. Yeah, just from the laws of economics, I can't think of an example where investors would put their capital at risk in a field that faces price controls. But I think it's also worth sharing a little bit about the odds of a drug making it all the way through the FDA. Only 1 in 25 drug candidates will make it from preclinical studies through FDA approval. And on average, the cost required to support a development program is between $1 and $2 billion. Keeping the incentive structure we have in place is clearly necessary to continue the output that we have.
I appreciate your input on that. I'm going to leave to our colleague Morgan Griffith to discuss about the takings clause and the constitutionality of the legislation. I think he tried to rescue it last Congress. I don't know if he's of a mind to try to rescue it this Congress, but again, I'll let him speak to that. Ms. Davis, if I could just ask you, are there any medications or therapy that your son is currently taking that would not be available in the countries the HR 3 international reference pricing is that concept is based upon?
So it varies on the type of patients, especially for the patients that are on ventilators. They are not able to access treatments in many of the countries because the quality metrics used to develop the inclusion criteria excludes those patients. Their lives are not deemed valuable enough to access the treatment.
So the calculation into the quality adjusted life year makes them ineligible. And by making them ineligible, what does that do to the outlook for their lifespan?
It significantly diminishes their lifespan. And not only their lifespan, but the quality of life during that lifespan.
So, we need to be mindful of things like that as we contemplate a bill like HR 3. HR 19 has a number of great provisions, all bipartisan. A number of them got passed in the last Congress. A couple of them have passed this Congress and been signed into law. So we ought, for my money, we ought to be working on what works, get it done, and let the American people help us sort it out. But I thank the chair for the recognition, and I'll yield back.
The gentleman yields back. Please note, I gave you 35 extra seconds there. The chair is pleased to recognize the gentleman from Maryland, Mr. Sarbanes. You have those shades on? Where are you?
I'm over here. Thank you very
much. There you are. Oh, we can see your.
Yes, thank you very much,
Madam
Chair. Appreciate the opportunity. Before his passing in 2019, Chairman Cummings, who represented Baltimore as I do and for whom this critical legislation is named, as you know, he worked tirelessly to uncover why the prices of life-saving drugs were so high that people simply could not afford them, why people would need to ration their drugs or go without. He felt this very, very deeply. I saw that every single day as he moved around his district, his neighborhood. Just couldn't understand why this was the case in a nation as great as America. We both heard, he and I continue to hear these stories today from Maryland constituents as to how the high prices of prescription drugs forces them to make impossible choices, endangering their health and their lives. And all of this is happening while drug companies continue to rake in these incredible profits. Between 2011 and 2016, we know that list prices went up 129% for 14 of the top-selling drugs. Top-selling because they're so critical for people out there. At the same time, out-of-pocket spending by patients increased by 85% for specialty medicines and by 42% for non-specialty drugs, even after taking inflation into account. This is just plain wrong. As former chairman of the Oversight Committee, a committee on which I also served, Chairman Cummings worked tirelessly, as I've said, to fix this problem. The Oversight Committee's work centered on both lowering prices for individuals and families across the country, as well as removing waste, fraud, and abuse from government spending, and our hearing today continues that effort. Professor Sachs, it seems like we're asking you the same basic questions over and over again. We're doing that because it's really important and because this bill can solve a lot of the challenges that Americans face. So tell me again, why is giving Medicare the power to negotiate such a central tool in effectively lowering drug prices? And maybe focus on the centrality piece of that. Like, there's a lot of other things that we can and we should do to address the high prices. But this specific tool of giving Medicare the opportunity to negotiate is really at the heart of it. It's in the center of our toolkit. So can you speak to that a little bit more?
Yes, absolutely. And just to clarify, because the prescription drug pricing issue is so complicated, there's not one reason why the price of a drug can be high or why patients might have difficulty affording their medications. It is important to ask and answer these questions in slightly different formats repeatedly so that we know what's at stake here for patients and innovation and access. So to answer your question more specifically, the centrality of negotiation to H.R. 3 is that it gives the government more authority to have an equal position at the bargaining table with these drug companies who are the manufacturers of high-priced sole source drugs. What do you do for Copaxone? What do you do for Humira? There's a question there about whether companies that have been on the market for a long time, who've now recouped their monopolies, but who've managed to delay generic competition, and it's really hard to crack down on 100 patents in a single drug portfolio or on some of these other tactics. Allowing the government to negotiate, just as many other countries do, would allow us to lower the prices of some of these drugs and get more fair prices for patients and payers.
Thank you. And it's so American to allow negotiation in the market. Yeah, it's the government doing the negotiating, okay, but that's the way it's supposed to work in our system, with two parties bargaining to get to a good result here. And obviously the government's hands have been tied kind of arbitrarily for years now. My understanding is that the CBO estimates the negotiation framework in HR 3 will lower federal spending by $456 billion. That's incredible. While also saving Medicare $42 billion on other health expenses, simply because beneficiaries will be able to fill the prescriptions that will keep them healthy. Let me just emphasize that. Because patients will be able to get prescription drugs that they cannot get right now, they will be healthier, and Medicare will save $42 billion on healthcare costs. Madam Chair, thank you for this hearing. Very, very important. I yield back my time.
The gentleman yields back, and thank you for having us look back at really the central work of our, as I said in my opening statement, our beloved colleague Elijah Cummings. In so many ways, he set the table for what we are doing today and going forward. It's a pleasure to recognize the gentleman from Virginia, Mr. Griffith, for your 5 minutes of probing questions.
Thank you very much. I appreciate it very much, Madam Chair. Let me just say that, and I got to get this off my chest, we've been talking about negotiations, but we don't have negotiations in this bill. And that's the problem, because what we have is a system that says if you don't agree to the price dictated by the government, you can pay a tax of 65 to 95% of the gross revenues for that drug in order to be able to sell it within the United States. Now, I get very concerned about that, as I did 2 years ago, because when it comes to the constitutionality of a bill, it's not just the courts that have jurisdiction to determine that constitutionality. This committee and Congress also have a role and have a duty to determine whether or not we're passing bills that are constitutional. The courts may be the final arbiter of that question, but we have a duty to look at it too. And when you look at the concerns that were raised, not just by me 2 years ago, but by others, including the Congressional Research Service, we have Eighth Amendment concerns. While Congress has the power to levy taxes, that levy is, or that ability is not without limitation, especially with regard to taxes that are actually more penalties or fines. And I think a court could reasonably find these taxes are, at least in part, punitive and therefore in violation of the Eighth Amendment of the Constitution. The one that I very first raised was the Fifth Amendment concern, and it's a takings clause, because when you say to somebody, you can't sell your intellectual property or your product in the United States unless you give us 65 to 95% of your gross sales, you're taking that property away from them. You're taking away their hard-earned intellectual property. And I have concerns about that. Now, I'm one of the people on the Republican side of the aisle that actually would consider negotiation, and I think we should have some negotiation ability, and I even have a bill in to do that in certain stressed areas. That being said, we have to do it in a constitutional manner, and Madam Chair, I just don't think this bill is constitutional. When you limit prices manufacturers can charge, and you say, you're being forced to accept the price for a drug, and that could mean significant economic loss for the developer, because you're going to take not of the profit, but up to 95% of the gross sales. That's a taking, Madam Chair. And I know that everybody's trying to do the right thing. And you've heard that HR 19 has some positives from the witnesses, and we've heard that there are other positives. But if we're going to do the right thing, even when we disagree, let's at least do it constitutionally. Now let me shift, before I finish my tirade, let me shift to HR 2843, because I think this one also has concerns. And I think we can all agree that FDA's citizen petition process can be very useful and must be implemented in a way that prevents abuse. And that bill, HR 2843, known as the Stop Games Act, seeks to address potential abuses. While I admire that goal, I remain concerned that the bill currently does nothing to resolve potential First Amendment issues, which I also currently raised back in 2019. Now, that deals with the First Amendment that guarantees the right to petition the U.S. government for redress of grievances. Yet, H.R. 2843 would allow the FDA to summarily deny, that is, to not even consider citizen petitions
at its own discretion, even if they raise valid scientific or regulatory concerns. If there is a scientific basis for petitioning FDA that has not been considered previously and has been timely submitted, I believe the agency should have a timely process to review the petition and make a decision based on the merits. Now, Madam Chair, I think we can both agree, and I think all of us can agree, that we need to have a process that's a little quicker. And right now it is being used and gamed by certain parties in the system to make this process long and drawn out. But again, let's figure out a way we can fix that without completely eliminating the right to seek redress from the government by citizens who may have a legitimate concern. And there are bad actors, and we have to figure out, how we set that system up. But I will submit to you that HR 2843 is not the vehicle, as it is currently written, that we ought to do that with. So, Madam Chair, I hope as we work forward in this, as we go through subcommittee, as we go to full committee with actual bills and the bills that we're discussing today, that we're open to doing some amendments to try to make sure that we can, even if I don't agree with it 100%, let's at least pass a product out of this committee that meets the constitutional test and that we can all feel comfortable is actually constitutional. And Madam Chair, my time is up and I yield back. Thank you so much.
Thank you. The gentleman yields back, always thoughtful. The chair now, with pleasure, recognizes the gentleman from Vermont, Mr. Welch, and I think I'm going to announce who follows. So just in case you want to step away, you know that your time is almost at hand, followed by Mr. Bilirakis from Florida. So Mr. Welch, thank you for all of the work you've done in the whole area of drugs and their costliness. You're recognized.
Thank you very much. First of all, we've got two lawyers following one another, and I disagree with Mr. Griffin on the constitutionality of this, but I do agree with many of the proposals that our Republican colleagues have in their bill. But the issue here is government negotiation. And there's a number, I'm going to step back for a minute and put this in a context. The pharmaceutical industry is dead set against governmental action through negotiation. And why wouldn't they be? They have record profits. Representative Castor mentioned that we pay 2 and 3 times the prices paid for the same drug in other countries. Pharma is not opposed to governmental action, and it is governmental action that provides them with patent protection and the exclusive right to use the product. Pharma is not opposed to governmental action when it comes to taxpayer financing of the National Institute of Health and all of the research that taxpayers pay for that then are oftentimes utilized and monetized by the pharmaceutical industry. Pharma is not opposed to governmental action when it comes to creating a guaranteed market in Medicare and Medicaid. So pharma has a pretty good arrangement. They've got a guaranteed market. They've got pricing power that is legislated and authorized by the government. And what we've seen is that it's a model that works, and they make billions and billions of dollars, and the CEOs make millions and millions of dollars in salary. Pharma oftentimes spends far more on advertising than it does on research and development. And all of these things add up to an incredible punitive price gouging impact on taxpayers, on individuals, and very significantly on many of our employers who are doing every single thing they can to maintain employer-sponsored health care for their valued employees. And when those employers get the notice from the insurance company that premiums are going up 15 and 20%, and then talk to their workers about this year, I'm afraid we can't have a raise because we've got to keep your insurance. All of that is continuing to occur and will never stop unless we address the cost. The biggest threat to access to healthcare is the cost of healthcare. It's the cost. So unless we face this, and the cost of healthcare is most exploding in the area of pharmaceuticals, we are going to allow the erosion of access to healthcare for the American workers, American seniors, and American kids. The argument is being made that if we proceed with price negotiation of any sort, it's going to adversely affect innovation. And I'd like to ask Professor Sachs to address that directly.
Thank you, Congressman. I want to say that as a property law professor, I share your skepticism of the takings argument. I'd be happy to discuss that in more detail at a later date. But to respond directly to your question about innovation, you're right. Industry argues that innovation will be harmed no matter what the reform is. They make this claim without regard to the size of the pricing reform, without regard to when in a product's life cycle it would take effect, without regard to what products it would impact. Today, they make this argument about H.R. 3, but they've also made it about bills that would crack down on paper delay arrangements or product hopping. HHS Secretary Alex Azar called this a tired talking point, and he was right. If industry won't distinguish between the CREATES Act and H.R. 3, then this committee should consider how seriously their arguments should be taken.
I'm going to have to interrupt you. Thank you. I just want to make 2 points. One, we've got to get rid of DIR fees that's hammering our local pharmacies, and they provide good service. And then second, I want to address this question of COVID and us having it and Europe being behind us. We negotiated with pharma to buy at a reasonable price the vaccine, and we funded them in their effort. In Europe, their problem was negotiation. They had 27 countries that couldn't come to an agreement on what a bid they would make. I yield back, and I thank the chair and my colleagues for this hearing.
The gentleman yields back. A pleasure to recognize the gentleman from Oregon. The gentleman from Florida. I'm sorry, Mr. Bilirakis, followed by the gentleman from Oregon, Mr. Schrader. So you're recognized for your 5 minutes. Great to see you, Gus.
Thank you. Good seeing you too. With all due respect to Mr. Schrader, my good friend, I want to remain in Florida. I do want to say this. I want to respond to my good friend Representative Castor with regard. She brought up the VA, and I understand there is an access issue. I know the VA does negotiate drug prices. However, 24 of the top 50 drugs on the national formulary are not covered by the VA, and I don't think that's a good thing for our veterans. And I understand only 63% of our veterans actually qualify, that are enrolled in the VA, get their drugs from the VA. So that's a big problem, folks, and we need to address that. There's no question. I want to get into now the rare diseases, if that's okay. And I want to thank the chairman for this hearing, very informative hearing. And I remain committed to working with my ENC colleagues on both sides of the aisle to put patients over politics by advancing bipartisan solutions. So that said, I'm very concerned about the impact of H.R. 3, patients with incredibly complex rare diseases. As you know, I'm the co-chair of the Rare Disease Caucus. Along with Representative Butterfield, we've done some really good things for our rare disease patients the last few years. So the bulk of R&D for medicines for rare diseases comes from the biopharma industry. In 2018, the biopharma industry invested $102 billion in R&D, 100% of which was focused on drug development. Contrast that with the entire NIH budget of fiscal year 2018, which was $35.4 billion, with only 8% focused directly on research related to drug development. We need a robust biopharma industry, and I think everyone agrees to that, investing in rare diseases. If reference pricing or similar policies are put into place, I worry that direct investment in rare diseases where the failure rates are high will diminish and companies will only, again, do the safe things, make the safe bets. And our children are suffering. Our people with rare diseases are suffering. And Representative Butterfield was right about that. 95% of these rare diseases have no cures or treatments. Very unfortunate. Policies like referencing pricing and government price settings will effectively turn our biopharma industry into a risk-averse, think out inside the box rather than outside the box commodity industry, and I'm concerned. That is not what American patients want. Okay, Dr. Kuka, I have a question for you. Can you speak to how HR 3 would impact complex rare diseases and investments there due to the economic incentives in HR 3 with a signal to manufacturers to invest in rare diseases or lower costs following up? What kind of an effect would HR 3 have on investments, R&D, with regard to rare diseases? Please.
Thank you, Congressman. Well, first, I think it's important to recognize that small biopharma companies are the ones driving innovation. They comprise about 70% of drugs in phase 3, and they're the ones that primarily serve rare disease patient populations. So they are the ones that have to seek raising capital from investors. And I think because of that phenomenon, and because rare disease populations are, of course, smaller, meaning that price controls would actually impact them disproportionately in terms of the revenue potential of medicines that are being developed. My belief is that price controls, as contemplated by HR 3, would significantly negatively impact rare disease patients.
Okay, one last question, and then I want to go to Ms. Davis, if I'm permitted. Ultimately, would HR 3 increase or decrease China and foreign influence over U.S. biomedical research? Yes or no? This is for Mr. Gupta.
I don't think it would increase influence over existing U.S. companies. I think it would give China a chance to equilibrate and develop an ecosystem to where they could start to bring innovative drugs to market.
Okay, I know I don't have, well, you know what, Madam Chair, I'm sorry. I'm not going to go over the time. So I'll yield back. Thank you. I just had the vaccine shot, so I'm a little bit fatigued, but I apologize for that. But I appreciate you giving me the time.
Well, thank you, Gus, and bravo to you for getting the, for being vaccinated.
My second dose, so I'm done.
Yeah, it's a great example to everyone else and the people in our country, and you give my love to Mom and Dad, all right? It's a pleasure to recognize the gentleman from Oregon, Mr. Schrader, and we're all grateful to you for your thoughtfulness, your work, and he'll be followed by the gentleman from Missouri, Mr. Long. So you're recognized, Kurt, for 5 minutes.
Thank you very much, Madam Chair. Appreciate the hearing. This is good stuff. Dr. Gupta, just trying to follow up a little bit on what my good friend and colleague, Rep. Bill Rockus was talking about. But on the flip side, if given your role in venture capital, if we were to do HR 3, how or would that impact investments in the biotechnology startup sector?
Thank you, Congressman. I think that the impacts would be far-reaching. They'd be wide, and they'd be generally negative. I think that if there are sectors that could seek that investment that provide safer returns or better returns, the prospect of that, you may see a diminishment of the types of risks that investors are willing to take in biotech.
Would there be any difference if instead of the benchmarking to a set price, we just allowed negotiations on the part of Medicare like we do VA and certain states Medicaid? Would that be different?
I think that it unfortunately doesn't help address the core issue, which I think remains the barriers to access primarily at the end of the funnel, which is out-of-pocket costs, and price controls of any sort do not ensure that the payers will pass those savings on to patients. So I hesitate to to suggest that there may be some amount of negotiation without focusing first on what we see as the larger problems.
Okay. I just saw negotiation is distinctly different than benchmarking personally. And we do that in so many other areas, and I assume that a lot of folks take that into account when they make their investments going forward. Ms. Sachs, you mentioned a couple of other topics you'd like to see the committee address, maybe at a later date, looking at other parts of the supply chain. I think this committee totally agrees with you. We've had numerous hearings over the last several years on this. Are there particular policies that address entities beyond the pharmaceutical manufacturers that you think we should be really prioritizing?
Yes, absolutely. So in particular, in thinking about the ways in which different actors have incentives to drive prices up rather than down, I do think it's important to look not just at the pharmaceutical industry, but also at the roles insurers, pharmacy benefit managers, and even physicians or provider groups in general can play in driving prices up rather than down. So this committee has already considered some of these proposals, but others would include taking a closer look at pharmacy benefit manager practices, at some of these issues in terms of spread pricing. I know this is also a topic of robust interest at the state level, with several state attorneys general interested in either having already brought lawsuits against the topic or certainly discussing so publicly.
You've also discussed a little bit about considering the linking of clinical value to price of drugs paid for, particularly by a governmental entity. Do you think that allowing governments to craft arrangements, for a drug, paying for it over a period of time or based on outcomes would be beneficial also?
Congressman, I actually think that's two different questions, and so I'm going to answer them very briefly because I know we're short on time. So first, this idea of value assessment. If we have two drugs that are treating the same condition, value assessment means we want to pay more for the drug that works better. And if we do that, companies will know that the better the drug they make, the more money they're going to make. They'll invest more in products treating unmet needs. But this idea of value-based pricing, which has come up already in a discussion today, that's what the pharmaceutical industry wants to call it, this idea of outcomes-based contracts. But there's nothing about either the initial or the rebated price of the product which are necessarily tied to its clinical value. So I like to call them innovative contracting models. The point I want to make about them is that they're voluntary for industry to engage in. Industry won't engage in these deals unless they think it makes them more money, not less. Right now, they're not required to enter into those deals, and that's certainly of concern for payers.
Well, that may be something we'd want to work on in the future to get at those concerns that you have. Now, I'm a big supporter of negotiating prices in the Medicare arrangement. We already do it VA, we do it for many states and Medicaid, but I also want to make sure we get something done. I do have some reservations about the indexing personally, and so do my constituents. I've heard from a bunch of them of late. But I think there's overwhelming bipartisan, bicameral agreement to work on some sort of solution here that encompasses some of HR 19, which is great, but doesn't go far enough. And maybe something not quite as robust as our HR 3. But I'm feeling good about the opportunity here and really appreciate having the hearing, Madam Chair. Thank you very much. I yield back.
The gentleman yields back, and you have our gratitude for your thoughtful work, Kurt. The chair is pleased to recognize the gentleman from Missouri, who's always, well, there's no one like Billy Long, so you're recognized for 5 minutes.
Thank you.
Followed by Mr. Cardenas from California.
Thank you, Madam Chair, and I appreciate it very much. I am saddened today that we can't tackle this situation, the drug pricing situation, the same way, with the same bipartisanship and the same enthusiasm that we did 21st Century Cures when you and Chairman Upton worked so hard with the entire committee. And I remember a vote coming out of the subcommittee that was 52-0. I don't know if that ever been done before. And I don't know what it takes to get back to that place in America. I don't know what it takes to get back to that place in Washington, D.C., but we all need to work overtime trying to get back there, because that was stellar. 10,000 diseases and 500 cures, and we tackled the problem with your help and Chairman Upton's help. The whole committee pulled together, and then we find ourselves in a cantankerous effort like we are here today. Dr. Gupta, it's clear that everyone on this panel wants to ensure that prescription drugs are affordable for all who need them. While we may strongly disagree on how to achieve the goal, there is bipartisan agreement that the Part D program can be improved. A redesigned benefit, which protects beneficiaries from high drug spending, is included in both H.R. 3 and H.R. 19. I hope that we can seize on this rare bipartisan opportunity to get these important benefit improvements signed into law this year and not get bogged down in a partisan fight over other drug pricing reform. Can you please elaborate on why it is important to cap beneficiaries' out-of-pocket costs in Part D?
Thank you, Congressman. Capping out-of-pocket costs is the key to ensuring access, ultimately, as well as, of course, incentivizing that new drugs are created. But, patient out-of-pocket costs in 2019 were about $82 billion. And we know that, 25% of patients will walk away when out-of-pocket costs are above $50. So it is important to eliminate those barriers to access.
I've heard from my colleagues on the other side of the aisle about the enormous profits that the biomedical industry purportedly reaps at the expense of patients. But many of the same companies, especially smaller startups in places like California and New York, are enormous job creators and constantly reinvesting their revenue into research and development and cutting-edge jobs. Dr. Gupta, could you please speak a little more to how H.R. 3's policies might impact the vibrant biotech job growth sector, not only in Silicon Valley, but in the rest of the country? And would you say that many of these jobs could move overseas if H.R. 3 were enacted?
Yeah, well, thank you. I'd like to start by reminding ourselves that the 1.4% of GDP that we spend on branded drugs, we get a lot of bang for the buck, not only in the improved health outcomes, but the economic output of our sector was over $1 trillion, and we employ over 800,000 workers in biopharma. 1/3 of those are in key STEM occupations, and most of the workers are highly mobile, highly desirable workers for any industry. If H.R. 3 and price controls are set in a way that it has the deleterious effects on the industry that we all think it would, I could see an impact on the significant impact on the economic output of the sector, affecting jobs, of course, in California, Massachusetts, New York, New Jersey, and across the country where the sector is, employs people.
I don't know if somebody's not muted or what, but I'm also on the telecom subcommittee, and I think I need to get to work on that as much as you were breaking up there on my end. So if anyone's not on mute, you might want to hit mute there. Dr. Gupta, sticking with you here, your testimony emphasizes much of the biotech advances being made in China in recent years. It seems they are already nipping at our heels and see biotech as an industry of enormous strategic importance. How do you expect China's strategy to change if H.R. 3 becomes law?
Well, I think we have tremendous advantages today in the United States because of the NIH, our tremendous public science funding, our tremendous university system. The only way China will ever catch up, the only way we'll ever fall behind is if we do it to ourselves. So my sense, I'm not an expert on China's policies or how they might react. My sense is that they would, really lean in on trying to catch up and trying to siphon as much of the talent, as much of the IP, and as much of the know-how as they can in a very defined way.
And if H.R. 3 were to become law, would it be as simple as flipping a switch to turn our biotechnology system back on if all of this investment does move to China and other countries?
Probably not as simple as flipping a switch. I think that we have tremendous advantages here, such as the NIH and the public university system, that we can always rely on, and we can always, go back to that well to reclaim our leadership advantage.
I hope that everyone got to see 60 Minutes on Sunday with China's chip development and our lack of chip development. I don't want to see that go into the drug phase. I'm over time here, Madam Chair, and thank you for having a great hearing today. And with that, I yield back.
The gentleman yields back, and thank you, Mr. Long, for highlighting what the biotechnology industry represents in our country, certainly in my congressional district. It's a great source of pride to anyone that represents them because of the innovation that they produce. In fact, for big pharma, the big companies look for innovation to the biotechnology industry and acquire them for because of their innovation. So thank you. The chair now has the pleasure to recognize the gentleman from California, Mr. Cardenas, followed by Mr. Mark Wayne Mullen of Oklahoma. So you recognize Tony for 5 minutes. Great to see you.
Thank you, Madam Chairwoman, and I appreciate you and Ranking Member Guthrie for holding this important hearing, and thank you to all the witnesses for your expertise and opinions today. We know that lowering prescription drug costs is a priority for all Americans, and I think that lowering healthcare costs overall is a priority as well. Even before the pandemic, 1 in 4 Americans reported difficulty affording their medications. Our current economic reality has only made it worse. As the wealthiest country in the world, the high cost of prescription drugs is unjust and for too long, and it literally has become a matter of life and death for many families and many children. No one should be forced to ration or avoid taking medications due to whether or not they can afford it. This is not what Americans or any person deserves, and I'm glad that our committee is working on the solution to address it today. And I hope that we can continue this fight to address the other 90% of costs that Americans are concerned about when it comes to healthcare overall. And as we prioritize affordability for patients and families, it's also important that we ensure research, development, production of existing and new medicines can continue to make it to market so that we can have more cures and more lives saved, and also the quality of life of Americans is improved. Ms. Ball, again, thank you so much for your testimony today and for sharing such a personal story, not only about yourself, but about the people you care for. Can you please expand on what it felt like for you to know this about patients who are rationing their care or who can't afford to get the care that they need because of prices? And what does it mean to you?
What it meant to me is that not only did I have difficulty with my memory and my physical being, I also had to stop nursing, and that was the love of my life. So that was huge. It also is what I see as all my fellow advocates, people that I have run into in special groups. They are past the point of what they can do. Their disease is progressing at a rapid pace, and they are not able to get their drugs. I think that we need to look at this, as you have said, that we need to get this bill passed in order for us to save the people in the United States with MS alone. I'm sure it's affecting almost every disease, those that are disabled, and also for the rare diseases. So it is something that needs to be dealt with. You can't imagine the 1.1 billion people will die from the fact that they didn't in the next decade for not receiving their medications. People in the United States should not, one, depend on charity to get their drugs, and people in the United States should be able to take care of themselves without having to depend on either charities or do I get my medicine or do I get my groceries. It is imperative that we take this and we take it for the fact that it's for all of us.
Thank you, Ms. Ball. Some bills we're discussing today involve biosimilars, biologics that are similar to other already Food and Drug Administration approved biologic medicines. I believe biosimilars play a role in helping lower prescription drug costs for patients across the board. That's why I've reintroduced the Increasing Access to Biosimilars Act. By authorizing a Medicare pilot program, this bill would help encourage physicians to prescribe less expensive biosimilars, promoting healthy competition and increasing patient access to life-saving prescription drugs by making it more affordable for them. Professor Sachs, could you please discuss your thoughts on biosimilars and how they could help increase affordability for patients and families?
Absolutely. And biosimilars and generic small molecule drugs are a key part of the social bargain. that we've made with drug companies, where we give them exclusive rights, patents, and FDA exclusivity periods, but we expect that at some point, competition through biosimilars and generics will enter and increase affordability for patients, increase our system affordability, and drive down prices. And the U.S. has yet to realize the full promise of biosimilar competition, and it is very important to consider bills that would increase biosimilar competition in the U.S., as biosimilar competition in Europe is quite ahead of us by quite some margin.
Well, one of the things that I have a problem comparing us to Europe is that the United States invests more money in R&D in this field than they do in Europe. In addition to that, in the United States, we have more talent, thank God. And the reason why we have more talent is because somehow, some way, we've been able to create that environment. Hopefully, we don't have a negative effect on that when we're trying to correct this issue of drug pricing in America. My time has expired. I'm sorry, Madam Chair. I yield back.
The gentleman yields back. It's a pleasure to recognize the gentleman from Oklahoma, Mark Wayne Mullen, and we all hope that your son continues to make the progress that he has been making, which is really miraculous. And he will be followed by Dr. Ruiz from California. So you have your 5 minutes for questioning.
Well, thank you, Chairman Eshoo, and thank you for always being concerned about my son. It's ironic because we're talking about drug pricing, and one thing that I had to point out that my son, he has to take a shot every week or every day, I'm sorry, and it costs about $4,900 a month now because of the
wow.
And sometimes the insurance pays, sometimes the insurance doesn't, and it's tough for my wife and I, much less thinking about when my son, who is 17 now, what he's going to do. I mean, when my wife and I got married, I was 19 and she was 18, and we were making $500 a week combined. I mean, we were just barely being able to get by, and to just think you're going to literally handcuff someone like that. And so when we're talking about drug prices, I understand it. I get it. It's something real to us, and we're having to deal with it. But I still have a little bit of a hard time with HR3. When you start thinking about HR3, it's government takeover of healthcare, and because when government gets into setting prices, then they are telling the manufacturers, which is independent from the federal government. They're entrepreneurs. It's what the United States thrives on, not government takeover, but of entrepreneurship. When you start telling them how much they can charge, it does affect what they do and what they're willing to invest in, because they're going to be capped on what they're able to get reimbursed for. Whereas my opinion is we should be looking at what's prohibiting competition from coming into the market. What's prohibiting individuals from entering the market? Why are we seeing a consolidation of pharmaceutical companies? Because with more competition, we would see prices come down, because they're going to be competing for our pricing. They're going to be competing for our business. If you're talking about insulin, or you're talking about the shot that my son has to take every night, because there's only one manufacturer that makes my son's shot too. And so there's no market. It's either take it or leave it. Dr. Gupta, I hope I'm saying that right. I know we've all been using different names to get to, but Dr. Gupta, is that how you pronounce it?
Yes, Congressman, thank you.
Okay. Would you agree that innovation is the best way in a market to control pricing?
Well, I think that's exactly right, and I think there's a couple of different aspects to it. As I've mentioned, the value we get from good prescription drugs via pharmaceutical purchasing, in terms of improved health outcomes, is second to none. We have to remember that these drugs that we're talking about keep people out of the hospital, thereby saving overall healthcare costs. And I think that's an important point to remember. And I think tying into your comments just a moment ago, when these drugs go generic, when there is competition, we as a society save over $200 billion a year, with $2 trillion a decade. And I think that's exactly the phenomenon that you were referring to.
So is it fair to say then that modernizing and recalibrating the natural price control, like the generic drug pricing, would help protect innovation and control pricing a little bit better then?
It would not just protect it, sir. It would actually stimulate it. The genericization of medicines is not only a natural price control; it actually stimulates innovative biopharma companies to develop new medicines. And as an investor, that's a process that we support.
Right. I appreciate that. So, with government control in a market, do you feel like that really creates more burdensome regulations that would prohibit new companies from entering into the market? Then,
I think we can all agree that we should be limiting barriers to generic competitors. I think there's been good ideas posited on that. And I wanted to make a quick comment in this regard on biosimilars. I mean, I see evidence of successful biosimilar entry in the U.S. as well. Biosimilars for drugs such as Avastin and Herceptin now have 50% market share. The originator company in those cases have started to offer discounts, and that's natural price control in action.
Right. Well, listen, I appreciate your time, Chairwoman Eshun. Thank you for always being concerned. Thanks for bringing this together too, because I do agree with a lot of my colleagues. There is room here for us to work on, and I think this affects all of our lives, and there's a lot of opportunity. I really wish we had a more bipartisan approach. HR 3, I don't think we really had a whole lot of say in. It's almost been like the committee's going to take it or leave it, and this committee's had a history of working together. And ever since we've been on it, we've had a history of working together. And I know you want to work with us. I know there's other people across the aisle that wants to work with us. And so I hope this is the beginning of us actually looking for a solution to have HR 3 work for all of us, Republicans and Democrats alike. So with that, I yield back.
Thank you, Mr. Mullen, and thank you for always sharing your story with us. The American people are tuned in to these hearings. I think they sometimes have a picture that is not quite accurate about individual members of Congress. The vulnerabilities in our families, what takes place in our lives. It's like holding a mirror up to the country. So I salute you for that. It really is very important. The chair is pleased to recognize one of the doctors on our committee, Dr. Ruiz of California, followed by one of our pharmacists in the Congress, Mr. Carter from Georgia. So you're recognized, Dr. Ruiz, for 5 minutes.
Thank you. Thank you very much for holding a hearing on this very important issue. And thank you to our witnesses for being here today. During debate over the drug pricing policies and how Congress should address access and affordability, it is important to remember why we are having this debate in the first place, which is the patient. Unfortunately, the patient and the importance of access to health and life-giving medication sometimes gets lost in the shuffle. But that is exactly what the core of this debate needs to be about. It's about the dad who can't afford the medication for his child and has to decide every month whether to cut corners on food for the family or medicine for his child. It's about the mom who is working 2 jobs to help pay for her aging mother's medicine while also paying for health care for her kids. It's about my patient who told me once that she collected cans to help pay for her insulin and told me that she figured out a way to afford her medicine by only taking half of the dosage to make it last longer, which makes her medicine, of course, ineffective. The average American often cannot afford their medication, even if they have insurance, even if they have Medicare. So seniors and families all across America are rationing their medications or going without them completely because they simply cost too much. And I know I'm hearing about it from my constituents, and I'm sure that everyone up here on the dais is hearing similar stories. For example, David, a senior from Beaumont, California, in my district, contacted my office recently to tell me about the heart medication his doctors wants to prescribe, of which there are no generic alternatives. The medication is so expensive that after the first 3 months of the year, David goes into the donut hole, where he will remain for the rest of the year, paying $3,294 in 9 months just for his heart medications. For seniors living on a fixed income, this not affordable and is not acceptable. Individuals and their doctors should choose the treatment based on what is best for the health of the patient, not primarily on whether the patient can afford to pay for the drug out of pocket. This system is unacceptable. America can and must do better, and it is time we do something about it. Healthcare is a right for everyone, and access to prescription medication should not be reserved as a privilege only for the wealthy few. Professor Sachs, thank you again for your testimony. There's a lot of discussion about the most effective way to bring down drug prices, including allowing the secretaries of HHS to negotiate prices directly with manufacturers, much like the VA does. So HR 3 requires the secretary to negotiate at least 25 of the most expensive sole source drugs in the first year, and at least 50 each year after that, as well as insulin. Would you agree that negotiating eligible drugs is the most effective way to deliver the greatest amount of savings and best use of resources? And do you think that HR 3's mechanism for selecting drugs for negotiation provide the most, quote, bang for our buck?
HR 3 certainly seems to be designed to provide the most bang for our negotiating buck. So the secretary is explicitly told to select for negotiation the drugs the secretary thinks will result in the greatest savings to either the federal government or beneficiaries throughout the relevant period. And it makes sense to phase in the program and start with the subset of drugs that's likely to deliver the most savings before expanding.
Thank you. And let's translate that to what it means for the patient. So CBO estimates that prices could be reduced by up to 55% for the first set of drugs negotiated by the secretary. So what impact would those price reductions have on healthcare out-of-pocket costs for the patient?
Well, as the physician, you're an expert certainly, but the CBO has said that if patients are more easily able to afford their prescription drugs, then they'll take those prescription drugs, and in at least some conditions, they will have lower overall healthcare costs. If you can avoid hospitalizing a patient because they're taking their medication on a regular basis, that's very important, and it can lower healthcare costs overall.
Thank you very much. You know, this is so important for our nation. It's not fair that America has to pay 3 times as much as other countries on the exact same medication. So America can and must do better. And I thank everybody for being here today. And I yield back my time.
The gentleman yields back. The chair is pleased to recognize the gentleman from Georgia, Mr. Carter, followed by our colleague, Congresswoman Debbie Dingell of Michigan. So you're recognized, buddy. 5 minutes.
Thank you, Madam Chair, and thank all of you for being here, to the witnesses. You know, as a pharmacist for over 30 years, this is the one issue that has frustrated me more than any other issue that I've tried to work on while I've been a member of Congress, because the answer is so simple and it's so clear. The problem to me, from my perspective, is the vertical integration that exists within our healthcare system. When you have the insurance company that owns the PBM, that owns the pharmacy, you have a vertical integration there by which anytime you squeeze that balloon, the only thing that's going to happen is it's going to go somewhere else. And that's what's happening here. Dr. Gupta, you referenced PBMs and the problems that they had in your opening testimony. And that is the problem. I know, I'm a pharmacist. I was a retail pharmacist, an independent retail pharmacist. I'm the one who signed the front of the paychecks. I had to make the numbers work, and I know where the problem is. And the problem right now is that you have 3 PBMs that are all owned by insurance companies. Someone made the point, I believe it was you, Dr. Gupta, that prescription drug prices are only a small percentage of the total healthcare costs. And they are. But the problem is, the reason that prescription drug prices are so high is because when you have Aetna that owns Caremark that owns CVS, when you have Cigna that owns Express Scripts, PBM, that owns Express Scripts mail order pharmacy, which, oh, by the way, is the second busiest in terms of volume in the nation. When you have United, which has the insurance, the PBM, and the pharmacy as well, then you have 3 PBMs that cover over 70% of the market. There is no competition there. And that is what has got to be broken up. And yet we tend in Congress to try to attack it from different perspectives. And then we have a bill like HR 3. I appreciate and I applaud you, Madam Chair, and I applaud the majority party as well as the minority party for trying to address this problem, but this is going to hurt more than it's going to help. I tell the story all the time. When I first started practicing pharmacy in 1980, if you were diagnosed with hepatitis C, it meant you were going to die because we didn't have a cure for it. Now, through research and development by the pharmaceutical manufacturers, you can take a single pill and be cured of it. That is nothing short of phenomenal. However, if that single pill costs $85,000 and you can't afford it, it does you no good whatsoever. The problem is we've got to break up that monopoly, that vertical integration. Dr. Guth, I want to ask you, how important do you think this issue is in saving patients would have if PBMs were held accountable, if the middlemen who bring no value whatsoever to the healthcare system, if they were made to be transparent and accountable?
Well, Congressman, I agree with you more. There is consolidation in the PBM industry and in general among prescription drug middlemen. In fact, of what we spend on prescription branded drugs, only 53% is estimated to actually make it back to manufacturers. So the middlemen are not just taking a small cut, they're taking, in many cases, a substantial cut. And transparency is key.
I'm sorry, Dr. Good, but what are they doing with that 47%? Are they putting it back into research and development? At least the pharmaceutical manufacturers are putting it back into research and development.
You're right, Congressman. I think that the middlemen have consolidated, and three entities have really outsized market power right now because they represent such a vast proportion of lives.
And my concern with HR 3 is it's going to stifle innovation. I mentioned hepatitis, and I mentioned all the other things that I've seen nothing short of miracles come out of research and development over my many years of practice in pharmacy. I think about my friends that suffer and that have family members who suffer from Alzheimer's. Right now, there are currently estimated to be almost 6 million Americans with Alzheimer's. But by 2050, the Americans age 65 and older with Alzheimer's is projected to be as high as 14 million. We've had 146 unsuccessful attempts to develop medicines to treat Alzheimer's. Dr. Goodwin, what's HR 3 going to do to research and development for potential cures for Alzheimer's?
I think it could be done. Not just Alzheimer's disease, ALS, and similar diseases where we haven't unfortunately made very much progress. We continue to try, we continue to take the bets and pour resources into them, but eliminating the potential for, incentivizing that innovation, I think could be devastating.
Madam Chair, I appreciate your indulgence. I'm just telling you, the solution is simple. It's right before us, and we're not getting it. We're not understanding that it's right. All we got to do is break up this vertical integration that exists within the healthcare system. If we break it up, we can do something about prescription drug prices. We can do something about healthcare costs. Thank you, Madam Chair, and I'll yield back.
Thank you, Mr. Carter. And I agree with you on the issue of PBMs. I really think that we miss an opportunity for a very important reform, and I've held that view for some time. So thank you for your consistent passion about that. The chair now has the pleasure to recognize the gentlewoman from Michigan, a name that is honored over decades in the Congress, Congresswoman Dingell, followed by one of our distinguished doctors on the committee, Dr. Neil Dunn of Florida, will follow her. Debbie, you're recognized. 5 minutes.
Thank you, Madam Chair. And my heart is with my pharmacist colleague too. We do need to talk about that, but I don't want to draw attention from some of the issues that we're talking about today. And Ranking Member Guthrie, thank you too, because this hearing is just so important because so many of us have constituents who simply can't afford their medicine. We've heard some arguments here today that if HR 3 were to become law, then there's a likelihood that innovation would be driven to China. I think that this is a red herring, let's be clear, because absolutely nothing in HR 3 is closing the U.S. market for drug manufacturers or drug development. The fact is that the United States is the largest pharmaceutical market in the world, and the pharmaceutical industry relies heavily on the premium academic institutions in the United States for their R&D work. There's no reason to believe HR 3 will fundamentally alter this dynamic. Innovation occurs where the best science is done, and the best science happens here in the United States of America. And there's no doubt that the U.S. will continue to be the world's leader in funding for basic medical science, and HR 3 provides additional resources to NIH to maintain our nation's role as a global leader in innovation. So Professor Sachs and Professor Carrier, we've heard claims today that China can run clinical trials faster than U.S. counterparts. But does that mean they're better? Americans expect that the drugs that they and their families are going to take should meet rigorous review standards in order to ensure they are safe and effective. Do you agree that the Food and Drug Administration is the gold standard for drug approvals in the world? And whichever one of you wants to go first.
Yes, I do think that the US FDA is the gold standard for the world.
I agree
Professor
completely.
Sachs? Yeah. Additionally, Professor Sachs and Professor Carrier, isn't it fair to say that China pays relatively low prices for drugs? Why would we expect the Chinese market have greater innovation potential than the United States?
That's absolutely correct. China pays lower prices for drugs than we do. And I think you put it well when you said that innovation occurs where the best science is done, not where the drug prices are the highest.
Professor Carrier, any comments?
Sure. So I think that one issue that we haven't talked enough about is the type of innovation that would be affected by HR 3. So we're not talking about that many drugs. It's only 8 to 15 fewer drugs out of a total of 300, according to the studies. And if you look at the type of drugs here, they're not the most revolutionary drugs. So for example, there is one study that just came out that looked at 122 ultra expensive drugs in Medicare, annual spending of $63,000 a year, and found that 73 to 85% of them have no or low additional added value. And so when we're talking about this, we're not talking about the blockbuster drugs, we're talking about a lot of Me Too drugs.
Well, let me ask you about that, because I hear from my constituents about the high cost of older drugs like albuterol. I mean, everybody on the committee knows that I cannot get the story of the mother out of my head who has to pay $800 for an inhaler. And so, for example, inhalers to treat asthma can cost hundreds of dollars, but they're decade-old drugs. Professor Sachs and Professor Carrier, how will the HR 3 framework incentivize new innovative frontline treatments rather than the older Me Too drugs that you just discussed?
Well, it will force pharma to create new innovations. Pharma has played all sorts of anti-competitive games, and they've relied on those games, and they've relied on charging whatever price they want in the US, so they don't have to do quite as much innovation. Sure, innovation in the revolutionary kind is hard, but to the extent you can rely on these tricks that have gotten you to this point, then there's no need to go beyond that.
I agree. Yes, my apologies. I agree. If you look at the top selling drugs in Medicare right now, Part B and Part D, most of them are over a decade old. These are drugs that have recouped their investment and have had plenty of protected time on the market. Negotiating for the prices of these drugs won't harm innovation in the future. It'll make space for future innovation in just the way Professor Carrier said.
Thank you both, Madam Chair. With 12 seconds left, I guess I'll yield those back.
Gentlewoman yields back. It's a pleasure to recognize Dr. Dunn of Florida, and he'll be followed by our colleague, Congresswoman Custer. Dr. Dunn, you're recognized.
Thanks very much, Madam Chair.
Thanks for your patience.
No, I appreciate your having this hearing. You know, we all know that the policies we make in Washington can have trade-offs, both good and bad. But any policy that will choke off investment in an entire industry, and an industry that's in the business of making cures, is bad policy. I want to associate myself with Dr. Gupta's testimony. I think we're living in a truly fascinating age of medicine and cancer treatments, gene therapies, CAR T therapies, monoclonal antibody treatments, and many more are in development or recently hit the market. And we all want Americans to have access to these new innovative cures. Americans already have access to more cures than do the citizens of the nations that H.R. 3 seeks to tie our drug prices to. Why take a step backwards and restrict access to cures for sick Americans? The quality of life metrics, so-called QALYs or quality adjusted life years, are built into the prices of some of our European friends pay for their prescription drugs. By these calculations, a treatment that extends the life of a disabled patient is worth less than a treatment for a young, healthy patient. This is not an attitude we should be importing, and it flies in the face of the American Disabilities Act. In Florida, the estimated impact of H.R. 3 is a loss of nearly $7 billion in economic output, 30,000 jobs, many of them at small and medium-sized biotech companies, and doing clinical research. H.R. 3 is an industry-killing proposal at a time when so many cures are on the horizon, and it is strikingly short-sighted in the wake of a global pandemic. To be clear, I think Americans should have access to the kinds of cures I'm talking about at an affordable price. We all want the prices to come down. I associate myself with Buddy Carter's remarks on that. But let's not destroy the American pharmaceutical industry and stifle innovation in the process. H.R. 19, the Lower Cost, More Cures Act, is full of bipartisan provisions to achieve just that. Fully 17 of these provisions were signed into law last year after careful bipartisan consideration. We passed transparency, reclassified insulin as a biologic, improved generic meds, etc. 40 more bipartisan provisions are included in the H.R. 19 bill this Congress, and it includes provisions to reduce out-of-pocket costs, learn more about the cost of middlemen in the pharmaceutical industry, combat shady practices, extending patents, etc. I am disappointed by the short-sighted effort to control prices at the cost of trade-offs that are just too harmful to patients suffering from many diseases. Dr. Gupta, I'd like to direct my questions to you. We just witnessed the incredible speed at which vaccines were developed in COVID. Can you think of any country on H.R. 3's international reference price list that produced and delivered multiple COVID vaccines to market over the last year? And do you relate that to the relative capabilities of the pharmaceutical industries in those countries before the pandemic arrived?
Absolutely. Thank you, Congressman. I think it's important to recognize that, for instance, there were certain therapies such as dexamethasone, which was a generic drug, which ended up being effective. Perhaps we would have been able to develop the monoclonal antibodies. I think we would have that served for acute patients. And certain types of the vaccines, including the adenovirus vaccines, may have been developed as well. But the mRNA vaccines, I think it's important to recognize that it was biotech investment over the preceding several years that laid the foundation that allowed them to be positioned to rapidly develop an effective vaccine in under a year.
Thank you. So let me charge ahead with our limited time. Dr. Gupta again, it takes 10, 15 years for a new treatment to make it through the pipeline. There are currently over 250 cell and gene therapies in early clinical stage trials, 17 for ALS, 16 for MS, and 300 for rare pediatric diseases. What happens to these potential cures if H.R. 3 is signed into law? And do you think the manufacturers will pursue approval for these drugs if H.R. 3 is enacted?
I think some of them may. I think some of them will try to do the math and realize that there's no longer an argument to be made to pursue it. I think that the longer stream danger is that it'll close up the funnel at the top end. And we might never get to 1,000, 2,000, or 10,000 cell and gene therapies in the pipeline, which is where we should be headed.
Good. So, I want to relate a quote from an Australian physician in the last few seconds here. He said, "I disagree with government decisions often because I want to use a medication which is shown to be a benefit and is a standard of care in the United States, and I just can't use it." That was by an Australian hematologist. This is what we risk if we go down the path of H.R. 3. Why on earth would we want to impart these frustrating, tragic stories to our practices? With that, Madam Chair, I yield back. Thank you again for having this important hearing.
We thank the gentleman and he yields back. The chair is pleased to recognize a good friend to all of us, the gentlewoman from New Hampshire, Ms. Custer, be followed by Mr. Curtis of Utah. Annie, you're recognized for your 5 minutes of questions.
Thank you so much, Chairwoman Eshoo, for holding this important hearing today to discuss legislation to lower the cost of prescription drugs for the American people. For too long, Americans have been grappling with the skyrocketing costs of prescription drugs and the current trajectory for what Americans, and particularly seniors on Medicare Part D, pay is simply unsustainable, and the status quo is unacceptable. For years, since I began running for Congress, I've been calling on Medicare to be able to negotiate the price of prescription drugs, a policy that has broad support amongst the American people and would generate literally billions of dollars in savings. So I am so pleased to see this provision included in the Elijah Cummings Lower Drug Costs Now Act. Legislative reforms to how we price drugs and medication in America should be a nonpartisan issue. It doesn't matter what your party affiliation is or where you live. Americans in every corner of our country are seeing more and more of their hard-earned dollars go toward prescription drugs and life-saving treatments. And that's why I am so pleased to partner with my friend and colleague, Republican Congressman David McKinley, on bipartisan legislation to create billions in savings for Medicare Part D beneficiaries. Last week, we introduced the Ensuring Access to Lower Cost Medicines for Seniors Act, which aims to ensure Medicare beneficiaries receive the full benefit of affordable generic drugs. The placement of generic and biosimilar medicines in the same pricing tier as more expensive brand drugs has led to seniors paying more out-of-pocket costs for their medicine. Our bipartisan bill seeks to reverse this trend by ensuring automatic coverage of lower-cost generic medications immediately after launch, and the creation of a dedicated specialty tier for specialty generics that offer lower cost sharing for seniors. The Ensuring Access to Lower Cost Medicines for Seniors Act could save seniors $4 billion per year through reforms to how generics and biosimilars are covered. And I want to thank Chairwoman Eshoo for including this bipartisan bill in today's hearing. Ms. Sachs, thank you for your testimony and for describing how some of the misaligned incentives it is how Medicare Part D operates. In your opinion, does Medicare Part D's design currently incentivize the coverage of brand name drugs, even when lower cost generic medicines might be available?
I would agree that there are elements of the Part D design which contribute to this, but it's also really about the relationships between the Part D plans and the PBMs as well.
So thank you. Several Part D plans offer more favorable formulary placements to branded drugs than they do to lower priced generics. Would the creation of a separate specialty tier for generic drugs in Part D have the possibility of lowering out-of-pocket costs for seniors?
It would absolutely have the possibility of doing that. And the reason is that today, a lot of seniors' out-of-pocket costs are based on the list price of the drugs, even if the negotiated net price is much lower than that. And so giving them those generic prices would be very helpful.
And do you have any sense of what the savings could be for seniors across this country?
I don't. That would be a question for CBO, but more generally, you're right to say that this is the type of bill which responds to some of the misaligned incentives, particularly involving the PBM insurance plan relationship.
Great. Well, thank you very much. I appreciate it. And Madam Chair, let the record reflect, I yield back with a minute to go.
You go. Thank you. The gentlewoman yields back. Pleasure to recognize the gentleman from Utah, Mr. Curtis, followed by our colleague, Ms. Barragan from California. So you're recognized for 5 minutes, Mr. Curtis. Nice
Thank
to see you.
Yes, very good to see you. Thank you, Madam Chair. It's been a very great hearing. Appreciate the comments of all of my colleagues. And I'd particularly like to associate myself with the representative who referred to this as good stuff. That's a great way to describe it. Mr. Gupta, I love to brag about the startup economy here in Utah, which is largely responsible for us being on the forefront of economic development and recovery. I'm aware of 20 startup biotech companies. They're working on cures for deadly diseases like COVID-19 and rare forms of cancer. To bring this home, in Utah alone, it's estimated that HR 3 would result in the loss of nearly 20,000 jobs and a loss of over $4 billion in economic output. My experience tells me that regulations like we're looking at in HR 3 are disproportionately hard and hurt smaller businesses. Can you share how you feel smaller startup biotech companies would access funding that they need in order to do the drug discovery and eventually drug development if HR 3 becomes law?
I'd be delighted to, Congressman, and that's particularly the intersection of biotechnology and finance in which I find myself, which is to say that reminding ourselves that it's smaller biotech companies that are primarily charged with bringing innovative products forward and represent about 70% of innovative drugs in phase 3 today. With price controls, I think that the smaller biotech companies will be disproportionately impacted, which is why the overall impact on innovation will be high. There might be larger organizations that will have other access to capital or be able to reprioritize, from large budgets, but small biotech companies will be very vulnerable to this legislation.
Thank you. Ms. Davis, while we were all touched by your story of Hunter, I'm told that many companies have patient assistance programs that help patients pay for costly medications at little or actually no cost. They also have cost-sharing programs to assist the insured patients pay for out-of-pocket costs. I'm curious, have you or any of your families benefited from these programs?
Yes, in my testimony, I discussed Ben, which participated in a free drug patient assistance program. I also know a number of patients that participate in patient assistance programs that provide assistance towards their co-pays, deductibles, and co-insurance, which have risen so high in recent years. And sadly, insurers have enacted co-pay accumulator programs, which make the benefits of patient assistance programs really inapplicable to patients.
Yeah, thank you. And quickly, Dr. Gupta, as a follow-up, is it fair to say that if HR 3 is enacted, this charity care would be among the first things that would see go away?
Congressman, I haven't contemplated that in the past, and I think I'd have to get back to you, actually.
Okay, I would love to know that.
Okay.
Let me also point out, Dr. Gupta, we know these rare diseases, they strike in an unpredictable and very cruel way. And as an example, I've lost 3 neighbors, and by neighbors, I'm talking within 2 blocks of my home, to ALS over the last several years. And currently, another neighbor and a very close friend of mine is an ALS patient. Fortunately, he has the resources to enroll in clinical trials for experimental therapies to treat his ALS. And quite frankly, he credits these trials for the very, very slow progression of the disease, which is unusual. If HR 3 were to pass, there are studies that indicate that there would be a 90% reduction in drugs developed by smaller biotech companies over the next decade, some of which could help ALS patients. Do you share the same belief that HR 3 would lead to reductions in competition and overall reductions in drug development?
Absolutely, and I think it's something that we heard earlier was that the types of drugs that would be eliminated would be primarily non-innovative drugs. I don't agree with that. I think that the types of drugs we would lose out on would be the most innovative, the most risky, and for the diseases where we've made the least progress, and that includes ALS, Parkinson's, and Alzheimer's disease.
Yes, and just in the few seconds I have left, can you explain the impact of HR 3 on clinical trials that have helped my friend and people like Ms. Davis?
It's a nice man.
Very briefly, I would say that I think it will reduce the incentive to fund clinical trials, which are expensive, and therefore reduce the number of innovative medicines available via clinical trials.
Very good. And Madam Chair, thank you very much. I yield my time.
The gentleman yields back. It's a pleasure to recognize our colleague from California, Ms. Barragan, followed by one of our distinguished doctors on the committee, Dr. Joyce of Pennsylvania. So you're recognized, Nanette. Great to see you.
Thank you, Chairwoman Eshoo, for holding this important hearing on legislation to lower prescription drug prices, including H.R. 3. Last Congress, we took some of the savings from this bill and reinvested them to expand Medicare. I hope that we decide to do that again, and this time to expand things like access to dental coverage for Medicare beneficiaries. 2/3 of seniors and individuals with disabilities in the Medicare program do not have oral health coverage. Oftentimes, these individuals are living on a fixed income, and beneficiaries struggle to be able to afford and receive dental care. I currently have a bill, the Medicare Dental Benefit Act, which is H.R. 502, which would expand Medicare Part B benefits to cover dental and oral health services, including things like routine cleanings, exams, fillings, crowns, major services such as root canals and extractions, emergency dental care, and other necessary services. I'm hopeful that my bill, as well as other proposals by my colleagues to expand Medicare services, can be considered as we move forward. Now, I want to talk a little bit about labeling exclusivity. You know, in addition to H.R. 3, today we consider my legislation to bring more competition to the drug market. The bill is called the Prompt Approval of Safe Generic Drugs Act. We know that as more generic drugs come into the market, prices drop dramatically. However, throughout our system, small hurdles remain for generic competition. And my bill addresses one example of how we can address that. Under current law, generics can be blocked from entering the market if safety information on a brand's drug label is protected under exclusivity, but no other hurdles remain. My bill would create a path forward for generic competition in these instances by allowing the Food and Drug Administration to attach a statement of an appropriate safety information to the generic drugs label to assure safe use. My bill stands for something quite simple. Safety information should be a feature of drug labels, not a bar to competition. Now, the FDA supports this legislation, and the CBO recognizes this is a problem, estimating that fixing it would save $164 million. Professor Carrier, I recognize this is just one issue we are discussing here today, but can you discuss how regulatory issues like this can promote competition and lower drug prices for consumers?
Yes, I can. Thank you for the question. And you're absolutely right that this is an important issue. There are many ways in which generics are not able to enter the market. And you put those all together and American consumers suffer because they're not able to afford their drugs. And so I appreciate your leadership on this piece of legislation. You're right that generics should be able to enter the market if the only thing that's blocking them is the label from the brand company. And so this would be one piece of legislation that could bring generics to the market faster.
Great, thank you. Another issue that we've been hearing a lot about today is just let the market do its thing, and that will take care of itself. And that hasn't happened. That hasn't worked. That's why Congress has to step in and do something. Just taking a look at things like insulin, where it started and where it's gone, is a good example of why we need H.R. 3 and why we need action. Communities of color, including my community that has a very high rate of diabetes, my district is almost 90% Latino, African American, low income, have really high rates. Professor Sachs, what will be the impact for diabetics, especially communities of color, if insulin prices are negotiated?
It could be very significant for health and for closing health disparities, because we have these decades-old drugs whose prices continue to rise year after year, seemingly without justification. So by lowering those prices, we can improve adherence and help mitigate some of those racial disparities.
Thank you, and thank you to our panelists and to the chairwoman. With that, I yield back.
The gentlewoman yields back. The chair now is very pleased to recognize the gentleman from Pennsylvania, Dr. Joyce, followed by our colleague from Delaware, Ms. Blunt Rochester. So you're recognized, Doctor. Good to see you.
Thank you for yielding, Madam Chair. And Ranking Member Guthrie, thank you for all the witnesses for being here with us today to discuss this incredibly important issue. I want to first talk about a case that I personally was involved with. 10 years ago, I diagnosed Charlie, a 62-year-old man with melanoma on his right thigh. And at diagnosis, the disease was only found locally, and further evaluation showed that there at that time was no spread of the disease. 2 years later, he developed evidence of metastatic melanoma involving internal organs. And then he received what was at that time standard of care therapy with interferon. And unfortunately, his melanoma progressed. Subsequently, he was started on one of the new immunotherapies that have been approved for metastatic melanoma, similar to what we know President Carter has subsequently received as well. Initially, his disease did respond to the therapy, but within weeks, the melanoma continued to spread. My then 64-year-old patient was started on a different immunotherapy to treat his melanoma. His response was remarkable and it was significant. He continued on that therapy until complete remission of the disease was attained. Today, 10 years later, he is symptom-free, he is disease-free. His imaging studies, which include CAT scans, MRIs, PET scans, show no evidence of disease. Last Friday, April 30th, I talked to Charlie on the phone, and he has such great insight on how the opportunity to have tried 2 different immunotherapies as a treatment for metastatic melanoma have allowed him to be completely cured. During that phone call, I asked Charlie if he had been given the opportunity to have tried a second immunotherapy, but not have had that here in the United States. He said I would have pursued it wherever I could. But given the opportunity to have tried a second immunotherapy after the first one failed, I asked Charlie, what does that mean to you? Charlie's very blunt and straightforward with me. He said, without the opportunity to have tried 2 immunotherapies to treat my metastatic melanoma, I would be dead. The drugs that he was allowed to use were Opdivo and Keytruda, and they presented huge advancements in the treatment of metastatic melanoma. The chance to have 2 therapies for metastatic melanoma has allowed today for patients to be cured. My questions first are for Dr. Gupta. Knowing that there are countless tragic stories of physicians in other countries who cannot allow their patients to have these innovations because they don't have access to it because of their government authority. Opdivo is only approved for 5 of the 14 indications in Australia, and in France, only 4 of the 14 indications are approved. This frustration should serve as a warning to all of us, to American patients, to American physicians, that if we go down the path of HR3, we're going to lose access, innovation, and cure. Dr. Gupta, as a physician, can you tell us more about what HR3's foreign price controls would mean for U.S. physicians and for the patients that you serve and the patients that need these innovations?
Well, thank you, Congressman, for the opportunity. And I think it's absolutely right that other countries have shown a willingness to block groundbreaking medicines from reaching their citizens. And I think that's morally indefensible. I think that's the last thing that we should be trying to import from another country. As a physician, having had the privilege of practicing medicine like yourself, what I most wanted for my patients was for them to get the medications that were prescribed to them. And there should be nobody coming between a patient and their doctor. And I think that we should not be emulating the systems that other countries have to blockade innovations from getting to patients.
So is it fair, Dr. Gupta, to say that American doctors could be put in that position where they wouldn't be able to prescribe what they know their patients need and what they know could cure their patients?
I think that's possible, yes.
And does that mean that these patients, particularly our most vulnerable, may be at risk for worse health complications, worse outcomes, restricted access to drugs and therapies were implemented?
Absolutely. As we've heard, not just days, but hours and minutes can matter. And it's a matter of getting innovative drugs to patients as fast as possible to help the most number of people. And I think that's what we all are attempting to do.
I thank you for your answers. Madam Chair, I thank you for allowing us to present and talk about access, innovation, and cure. And I yield my remaining time.
The gentleman yields back. It's a pleasure to recognize the gentlewoman from Delaware, Congresswoman Blunt Rochester, and she'll be followed by the gentleman from North Carolina, Mr. Hudson. So you're recognized, Lisa. Great to see you.
Good to see you, Madam Chairwoman. And thank you so much, Madam Chairwoman, for your leadership on this issue. I know we've talked many times about it on the floor as well as in committee, and I know this is a priority. And thank you especially to our ranking member and the witnesses for joining us here today. As evidenced by the interest and ideas of my fellow members, you can see that we all know that the current system is not sustainable and that the focus really needs to be on making sure that Americans are well and safe. And Ms. Ball, I especially want to thank you for sharing your story with us as someone who has both spent much of your life caring for others as a registered nurse and as a multiple sclerosis patient yourself. Today, you represent millions of Americans who are struggling to afford medications that improve their health and save their lives. The pandemic has been hard on many families like yours, and it is unacceptable that you and so many others should have to really choose between taking medications and paying your bills, and while the prices continue to rise. And so, Ms. Ball, you mentioned that the cost for your medication has gone up substantially over time. What did you mean? What did that mean for your out-of-pocket spending when your drug cost increased, and how did it impact your monthly budget for other things like groceries and gas?
When I received the information that I no longer had the grant, it was $6,000. I called so many pharmacies to see if it could be less. So basically, we tried to rearrange everything that we could as far as groceries and going to live at my daughter's house. Also having the fact that I wasn't able to practice anymore, so there was no income coming in. As far as groceries and such, when I made the final decision that I couldn't take the drug, that kind of put it back in a little bit into perspective. But in essence, it is a very difficult. When I did my $1,800 at the very beginning of my diagnosis, I had to move to a smaller place. There was many things. And I had the advantage of having a family that could help me. And there are many of us out here that don't.
I know you talked about the increase in the price year after year. What sticks out to you the most about that experience?
I guess what sticks out to me is that if they would have been doing something innovative, if they were doing something that was reaching to a cure, I could have understood even for a small amount of time because they have to pay for what they are doing. But the fact that all it was a way of them to take the price up for something that is absolutely the same. It wasn't really approved in the sense that they didn't think it made the FDA and the people from NIH didn't feel that it had given any kind of improvement, and it didn't. So that's a lot of money that people are putting out for something that's not coming close to a cure.
And what do you think that this means for retired Americans who live on fixed incomes? And lastly, from your perspective, could you also talk about the inflation rebate proposal included in HR 3, and if you think that that would help you afford the prescriptions that you need?
Well, for people that have that are retired, such as myself, it is very difficult because you only get so much in Medicare. So if you have a $2,000 cap, which would be great, and you don't have the amount of money as far as negotiating the money for us to get the right amount of money to pay for it, the 2,000 cap won't help. So we need to be able to do that. And I must apologize, I'm not very well versed on that part of that because I have never had to work with it. But thank you for asking me.
No problem. Thank you. And Ms. Sachs, I just had a question for you. What do you say to people who say that HR 3 won't actually lower the cost of drugs?
I say that it absolutely will lower the cost of drugs, not only for patients, but also for payers. And here, I think the CBO's estimate of how much it would save, $456 billion over a decade. If that's off even by a little bit, it would be a tremendous savings for American patients, savings which could be used to expand access to insurance more generally.
Thank you so much. I think what we have heard today is that this is a complex issue, that we need to be comprehensive in our approach, and that we need to make sure that we are watching out for our constituents, as well as not stifling innovation. I believe that we can do it, and we need to do it. Thank you so much, Madam Chair, and I yield back.
The gentlewoman yields back. It is really a pleasure to welcome back to the committee our wonderful colleague, Mr. Crenshaw. A lot of us prayed for you. It's great to see you. Hope you're feeling 100% better, and that what you endured has brought you back to full eye strength, and I'm so happy to see you. I hope you got my message too. So you're recognized for 5 minutes, Mr. Crenshaw, and you'll be followed by our colleague from Minnesota, Ms. Craig. Mr. Hudson had to leave, so that's why you're next. Really nice to see you.
Oh, thank you for the kind words, Madam Chairwoman. It's a pleasure to be with you all. I still can't see you. So, but I do feel better. I should see normally in a few weeks, I hope. I've got to wait for this procedure to sort of follow its natural path. So, but we're optimistic that I'll have some sense of normal in a few weeks to a month.
Great.
Thanks for all the wishes. Really appreciate it. But like I said in the last hearing, even a blind knuckle dragger can do hearings. So here we are. Look, this bill is really important. I've been talking about this bill for a long time, and I appreciate us doing a hearing on this really important topic. I think we all want lower drug prices. I think the question is, how do we get there without killing the goose that lays the golden egg? There's been a lot of concern about innovation. There's been a lot of concern about the fact that when we reverse incentives to invest, and one study shows that this will directly hit the smaller biotech firms. Over 90% of them will reduce their investment. We'll see a massive decrease in new cures that could save lives, that could reduce healthcare costs in the long term. And we've talked a lot about negotiation. And Ms. Sachs, this question is for you. Is it really fair to call the process laid out here a negotiation?
Yes, I believe it is. Nothing in HR 3 tells a pharmaceutical company what they can and can't charge. They limit how much those companies are able to demand those prices of the federal government.
Right, but if they don't come to the table with the federal government, they're levied a 95% tax on their revenues, correct? That doesn't seem like a negotiation. It seems like an extortion.
And right now, Medicare is a price taker. They have to accept the prices being demanded by pharmaceutical companies and have relatively little ability to push back on those prices. That's not how a free market negotiation works.
Right, but if I'm the government and you're a private citizen and I want your services, and you say, well, for that price that you're offering me, sir, I won't give you my services. And I say, if you don't give me your services, I'm going to levy a tax on you, 95% of your revenues from now on. That's not a negotiation, nothing close to it. The other problem I see with the process laid out here is, again, it's called a negotiation, but that's not how bureaucrats work. It can't work that way because of the Administrative Procedures Act, because of Section 1871 within Medicare. It can't possibly work that way. It can only work as a formula. And so it's just simply false to say it's a negotiation, isn't it? Isn't it just price setting?
So I would welcome more details on how the Administrative Procedure Act is a barrier here. It's not entirely clear to me how it would be. What I will say is that CMS...
I'll tell you. I'll explain it really briefly. What it basically says is that you have to have an objective way of setting a price. It can't be subjective. And of course, this makes sense because we can't give one company a subjective negotiation, say, hey, you know what, we'll give you 90% of your costs. And then we say, give another company only 80% of the cost. You're a lawyer. What would happen? You'd have lawsuits. You'd have endless lawsuits. That's why we have these procedures in place.
So what we have here is a clear delegation to the Secretary of the criteria they should use in engaging in negotiation.
Exactly. And every lawyer we've talked to, every single one says there's only one outcome that will happen here. The secretary will set up a formula. It's not going to be the secretary talking to the CEO of Pfizer, is it? No, it's going to be a mid-level bureaucrat. That mid-level bureaucrat isn't allowed to think subjectively about how they negotiate, right? They have to follow a formula. There's going to be
that's a mischaracterization of HR 3.
But that's exactly how it'll be interpreted into the rulemaking, wouldn't it?
No, I think there's no reason to believe that would be the case.
Every other lawyer we talk to, counsels from CMS, counsels from CRS, say that that's exactly how this would be interpreted. In fact, it has to be according to Section 1871 from Medicare.
I think what's important here is to remember that we're talking about paying prices that are closer to the much lower prices that are being paid abroad. And that's setting up the framework for this broader negotiation. And the Secretary is given the discretion to use different criteria to negotiate within that framework.
And that may be the case for older drugs, but newer drugs will simply not be invested in. Again, I don't dispute your earlier comments that it would immediately lower drug prices. Of course, I mean, by law, it's making their drug prices lower. The concerns we have are, of course, with innovation. And look, let's get philosophical for a second. I think that if we had all the cures, all the drugs that we would ever want for the human race, right now, they existed, you could make a good moral argument that the government could just confiscate them and deliver them to people, right? You could make a moral argument that way. But of course, that's not the situation that we're in. The situation we're in is that we want more drugs available to us. In America, we have access to a lot more innovative drugs than any other country. There's a study of the over 300 new drugs approved since 2011. America has access to 87% of them. Something like Australia has 39% access. So the UK is 50%. Canada has less than 50%. So innovation's a big deal. I don't know who was just talking, but I reclaim my time. Ms. Davis, I don't know if I have more time.
Crenshaw, your time, I'm sorry, your time has expired. You're over by.
Thank you, Madam Chairwoman. Sorry, I can't see the timer. I apologize.
Yeah, no, that's all right. Thank you. I gave you a little more time so you could finish a couple of your sentences there. And again, we're really thrilled that you're back. Keep making progress.
I appreciate it, Madam Chairwoman.
Please.
Thank you for indulging me. I'm sorry, I can't see the timer.
That's all right. That's okay. Now it's a pleasure to recognize the gentlewoman from Minnesota, Congresswoman Craig, to be followed by, we don't have any Republicans left, so there's going to be a string of Democrats following the gentlewoman from Massachusetts, Ms. Trahan will follow Congresswoman Craig. So great to see you, Angie. You're on.
Thank you so much, Madam Chair, and thank you to our panelists for your patience and resilience here today in this hearing. Look, the burden of high out-of-pocket costs for drugs on Medicare beneficiaries is significant. Over the next decade, approximately 1.1 million older adults are predicted to die prematurely due to this cost burden. One study found that if Medicare is able to negotiate lower drug prices and cost-sharing responsibilities for beneficiaries are reduced, it may decrease premature deaths by about 94,000 per year and generate nearly $500 billion in savings by the year 2030. This is particularly important for those today who must choose between filling their prescriptions and treating their illnesses or paying their bills. Bob Miller is a constituent of mine living with MS. Over the course of 12 years, the list price of his medication rose from $13,000 a year to over $103,000. While on his employer's coverage, Bob was able to get copay assistance to make the drug affordable for him. But under Medicare, he is now ineligible for that same type of assistance. Faced with the reality that the cost of his drug that would jeopardize his retirement security, Bob opted to stop taking the drug. He understood he was rolling the dice on his health, and he wants Congress to act so that no one else must make this life-threatening decision. So let me start with Professor Sachs. Can you generally describe how HR 3 will benefit low-income people in particular? Recognizing that some people have access to cost-sharing assistance through the low-income subsidy, may already have some help, but what about others who don't qualify for this extra help? How would their out-of-pocket expenses and premiums potentially be lowered?
Thank you. And this is an important question to think about where the low-income subsidy phases out and how it isn't helping enough seniors who may be on fixed incomes especially. So this out-of-pocket cap would be particularly helpful for seniors who are just out of low-income subsidy qualification, but who have these expensive out-of-pocket costs.
Professor Sachs, you heard my statistic that I cited there. Do you agree that lowering drug costs and reducing out-of-pocket expenses could prevent death, as recent studies have shown?
Yes, relying on those studies. And it's really easy to see how that's true for something like insulin.
Absolutely. Additionally, the Congressional Budget Office has estimated that the Medicare program will save billions because people can finally afford to take their medications. Do you expect HR 3 will also lead to better health outcomes?
Yes, especially or potentially for low-income beneficiaries, given those high out-of-pocket costs that they face today.
Thank you so much. You know, I recently introduced HR 2464, the More Help for Seniors Act, that would expand the ability for seniors to receive extra help under the Part D low-income subsidy program. Not only do we need to provide more help to low-income seniors so more can take advantage of the program, we need to effectively reduce drug costs for everyone. That's why I personally believe HR 3 is so important. It's clear that lowering costs for seniors will not only improve their lives, but research has shown that for thousands of people each year, it will also save lives. And, you know, I've got just a little more than a minute left. And I just want to say that much of the question and discussion here today, as someone who spent more than 20 years working in medical technology for a company that had to compete for to be on the VA contract every couple of years. Some years we were, some years we weren't for the technology company that I worked for. I just have to say that the sky is falling dynamic here is just frankly unbelievable. And if you look at net operating profit for any large brand name pharmaceutical drug company in this country, it's really hard for me to believe that this sector that has continued to just increase price, has never really been held to account here. Look, we know, we all agree that we have to balance innovation, but at the end of the day, I think this sector in healthcare, you know, has been able to escape any or much of the accountability in this country for what has happened with drug costs. And, you know, let's talk about, we don't have time today, but, you know, specialty drugs and compound drugs. Look, this sector needs more competition, not less. And at the end of the day, Medicare, just like the VA, should be able to negotiate its drug pricing in the United States of America. And with that, Madam Chair, I yield back.
The gentlewoman yields back. We all benefit from your membership on our subcommittee. And now the chair, with pleasure, recognizes the gentlewoman from Massachusetts, another new member to our subcommittee. All of our new members are just such value added. I keep saying this every time I introduce them, but I think that it's important to reiterate. The Congresswoman from Massachusetts, Ms. Trahan, and she will be followed by our colleague from Texas, Ms. Fletcher. So, Lori, thank you for your patience.
Thank you so much, Chairwoman Eshoo.
I love seeing the backgrounds of everyone. They're so varied. Yours looks especially lovely.
Thank you. I appreciate that. And I appreciate this hearing, our ranking members, certainly our witnesses who are with us today. I did want to respond to my colleague's argument that if HR 3 was in effect, we would not have COVID-19 vaccines and treatment, which I find to be misguided and would like to just spend a bit of time clearing. or setting the record straight. You know, as my colleagues will remember, last Congress, we passed billions of dollars of funding for NIH and BARDA to aid in the research, development, and manufacturing and purchase of COVID-19 vaccines and therapeutics. We just followed that up with even more in the American Rescue Plan a few months ago. That funding, along with the hard work and expertise of NIH and BARDA, and yes, our private pharmaceutical manufacturers, led to the development of several safe and effective vaccines. This has been a collaborative effort. Take the Moderna vaccine, for example, the first product the company has ever commercialized. The United States invested $2.5 billion in clinical research, development, manufacturing, and purchase of just that vaccine, removing almost all of the risk for the pharmaceutical manufacturer. And before last year, Moderna was already relying on the work of the NIH to help develop its mRNA technology. Almost all of the company's investment in its vaccine came from these federal dollars. I'll also note for the Pfizer vaccine and all of the authorized vaccines, the federal government negotiated the price it would pay. These resources went to manufacturers due to the bipartisan work of Congress, which paid off massively for the American people. So negotiation never would have hurt the ability for vaccines to come to market, and using that as a scare tactic just doesn't stand up to the facts. You know, Professor Sachs, I'd love for you to just comment on this. It might be helpful just to hear unequivocally, you know, if H.R. 3 had been enacted prior to the emergence of COVID-19, would it have impacted the ability to bring COVID-19 vaccines to market?
Absolutely. And I want to be clear, nothing about H.R. 3 would have impacted the creation of Operation Warp Speed or development of vaccines and treatments for COVID-19. And in fact, Operation Warp Speed, as you said, it helped encourage the development of new vaccines. That's exactly the type of government initiative which disproves the idea that there's a trade-off between innovation and access. And then just one more brief comment. This is what's important. Congress made the decision that patients could not be charged out of pocket for these products. They were to be provided free at the point of sale or treatment to those patients. So we have both innovation and investment from the federal government and no cost access for patients.
Thank you for that. Well, H.R. 3 takes a bold step to flip the status quo in a system that has made billions in profit while working families like the one I grew up in are struggling to pay for their life-saving medicines. Ms. Ball, I just want to thank you once again for coming here today. Your story is one that resonates personally. You know, my father has had MS for the past 27 years, and in the early days when he was healthier and could walk, he would come to Capitol Hill for patient advocacy days. And I've seen the sacrifices that he and my mom have had to make for his treatment and care. You know, MS is an unpredictable and it's a costly disease, and your testimony today was so helpful. In my remaining time, I think one critical area that I think must remain at the center of our policy discussions is health equity. We've had so many hearings that have highlighted the disparities that exist across our healthcare delivery system, and prescription drugs are no exception. Given the disproportionate impact that the pandemic has had on communities of color, Congress does have an urgent responsibility to address those disparities that have long predated COVID-19. And so, Ms. Sachs, with the remaining time, it's common sense that if people can afford to take their medications, that they will remain healthier. How will the policies in H.R. 3 lead to better health outcomes for low-income communities and people of color?
Yes, it's certainly my hope that the lower drug prices created by H.R. 3, both through the Medicare out-of-pocket cap and the negotiation provision.
Thank you. I appreciate that. I'll yield back the no time I have left.
I would thank the gentlewoman. Excellent line of questioning and observations. I'm proud of all the members of our subcommittee. I think that it's the best subcommittee at Energy and Commerce. How about in the whole House, everybody? That's how proud I am of you. Okay, now the chair is going to recognize the gentlewoman from Texas, Ms. Fletcher, and then following her, there are 4 members that are waving on. And then our colleague, Dr. Kim Schreier, has asked to be last because she has a conflicting event. So I don't want anyone to think that I'm leapfrogging over her. So pleasure to recognize you, Lizzie, and you have 5 minutes, and then we'll take the members that are waving on to our subcommittee today.
Well, wonderful. Thank you so much, Chairwoman Eshoo, for holding this hearing today. Bringing down the cost of pharmaceutical drugs has been one of my top legislative priorities, and it obviously is one of this Congress. As we've heard today, there's been a bipartisan priority for many, and many of the bills being considered today have bipartisan support. But a lot of the questions and comments in today's hearing seem to have presented us with a false choice between lowering drug prices for Americans and developing innovative new treatments. So I'm really grateful to our panel for insights, all of your insights today, and I'd like to focus a little bit on this issue, the idea that high drug prices provide a funnel for innovation, and if profits decline, it will impact efforts to find new cures. You know, at the same time we hear that, industry experts have noted that the pharmaceutical industry is one of the most profitable sectors and sees greater profits than other industries on the S&P 500, for example. So, Professor Sachs, can you briefly discuss whether there's evidence for the claim that high drug prices are truly the conduit for innovation? Would the pharmaceutical industry continue to invest in R&D if HR 3 became the law, or would it no longer invest in R&D if we were to pass HR 3?
They absolutely would continue to invest in R&D. Now, to be sure, there are projections that there would be a small decrease in the number of drugs coming to market over the next decade or more as a result of HR 3. But I want to emphasize that it's not just the amount of drugs that we get, it's the kind. We've heard a lot of discussion about the importance and the need for cures. And I absolutely agree with that. We don't just want new drugs, we want good new drugs that fulfill unmet needs for our patients. And economists looking at the creation of Medicare Part D found that it gave a large new subsidy to pharmaceutical companies to do innovation, but that most of that innovation was concentrated in disease classes with lots of existing treatments. So if we're lowering prices a little bit in Medicare Part D, we might be taking away some of those Me Too drugs, but there's no reason to think that we would be limiting incentives for companies to develop these truly new cures, because these are exactly the products that command very high prices in other countries against which we would be referencing.
Well, thank you for that. And that your answer touches on another issue that we've sort of covered a little bit today, but I think when it comes to sort of research and innovation, we've talked a little bit about the funding that we have done recently, and there's funding in HR 3 for research and development and innovation. There's $10 billion of direct funding to the NIH to bolster research in cancer, rare diseases, regenerative medicine, antibiotic resistance, and treatments for substance use disorders, among others. There's also in HR 3 $2 billion to the FDA to enhance drug development, review, and safety, including investing further in activities authorized under the 21st Century CARES Act. So, I think that that's important when we talk about research. And Ms. Sachs, would you agree that investments in the NIH and FDA, like these efforts I just described, could help enhance research and development on new drug therapies?
Absolutely. And one example of that is we've heard somewhat today about the fact that we really want new drugs for conditions like Alzheimer's. But we've also heard about the fact that even today we have hundreds of candidates which have failed clinical trials. So even today, without HR 3, we don't have these effective new therapies. What we really need is some public investment in figuring out more about how some of these diseases work, about what approaches might be important for private pharmaceutical companies to pursue. So HR 3, developed in 2019, isn't the reason that companies have failed over the last decades to find new drugs for Alzheimer's, and it's not going to prevent us from finding a solution either.
And thank you. With the little bit of time I have left, there's also some recent research that shows that many of the patented prescription drugs, like some of the innovative things we're talking about today, were actually first discovered through taxpayer-funded NIH research and grants. Is that your understanding?
Yes, and I think we also just heard a little bit about the Moderna vaccine, where there was a huge amount of public investment, not just in the development, but the partnership with the NIH in completing those clinical trials. So that's a very recent example where that's absolutely the case.
Well, thank you so much, Ms. Sachs. And in the time I have left, I just want to thank all of our witnesses. This is clearly a really important topic for our constituents and for people across the country. So in addition to supporting innovation, HR 3, as well as some of the other legislation we're discussing, is really the critical legislation we need to lower prescription drug prices so Americans can live longer, healthier lives. And with that, Madam Chairwoman, I yield back.
The gentlewoman yields back, and we thank her. Now we will go to 4 members that are members of the full Committee of Energy and Commerce, and they're waving on today, and we welcome them. The first will be the gentleman from Illinois, Mr. Rush, followed by the gentlewoman from Colorado, Ms. DeGette, followed by the gentlewoman from Illinois, Ms. Schakowsky, followed by the gentleman from Florida, Mr. Soto. So do we have the gentleman from Illinois, Mr. Rush?
Thank you, Madam Chair. So delighted to see you once again. I want to thank you for allowing me to participate in today's important hearing on HR 153. I'm also very pleased, tickled pink, if you will, that this subcommittee is once again considering HR 3, the Elijah E. Cummings Lower Drug Cost Now Act, which I am proud to co-sponsor. Madam Chair, these bills will take important steps to ensure affordable drug prices for Medicare recipients and patients of all ages throughout the country. Professor Carrier, it is nice to see you once again, and I appreciate your coming back to once again testify on my bill, the Protecting Consumer Access to Generic Drugs Act. While you and I have worked to stop these insidious practices of what is called pay for delay for far too long, is inarguably a complete and complex issue. Can you walk us through an example of a time when this practice has hurt consumers and led to higher drug prices for American patients?
Sure. So thank you so much, Representative Rush, for your leadership on this issue now and your leadership going back for years. You have discovered the problem of pay-for-delay settlements as early as anyone has. The problem with pay-for-delay is a brand company pays a generic to stay off the market, and that generic could be delayed for years. And so there are multiple examples involving drugs like Impax and Bolstering and the antibiotic Cipro, many drugs that are worth a lot in terms of revenue, where the consumer is delayed getting an affordable drug for years.
Thank you very much. Also, Professor Carrier, I appreciate your thoughtful suggestions to strengthen HR 153. Can you please, or would you please, walk us through each amendment and explain why they're needed to stop the practice of pay for delay once and for all?
Sure. So for starters, I think that your bill is an excellent approach to the problem. The Supreme Court in 2013 said that pay-for-delay settlements could violate antitrust law, but the settling parties, and here we include the generics, because the settling generics are just as bad as the brands here, they do everything in their power to muddy the waters, to say that it's not really a payment, or that it's a payment for generic services, not really for delay, or that there's no delay because the patent's good. And so your bill would really solve this problem by dealing with the FTC and giving the FTC the power to go after this in court in a way that's really hard now to fix some of these mistakes that courts have done, like not recognizing payment, like adopting the scope of the patent test. And so if you were to consider other changes to the legislation, I suggested things like applying it to the Patent Trial and Appeal Board. So this is one place where the settling parties are trying to hide payment. PTAB settlements, Patent Trial and Appeal Board settlements, are not reported to the FTC. So that would be one place to start. Don't let them hide it there. Include that in the bill.
Thank you so very much. Let me move on to Professor Sachs. Professor Sachs, in your testimony, you discussed various mechanisms other countries have implemented to strengthen the hands of their payers to the negotiating process to drive down prices. Have these policies led to life-saving prescription drugs not being covered in other countries? And more importantly, how does HR 3 ensure Medicare can effectively negotiate without patients losing access to the medication their doctors have recommended and prescribed?
Thank you, Congressman. And to your question about how HR 3 would protect Medicare beneficiaries' access to these medications, it's important that nothing in HR 3 changes, that Medicare is obligated to cover at least 2 drugs per class, all drugs in the 6 protected classes. Nothing about HR 3 changes that.
I want to thank you very much. Madam Chair, again, thank you for your kindness, and I yield back no time because I don't have any time.
Well, thank you, Mr. Rush. You're always welcome at the subcommittee, and thank you for your important legislation. Excuse me. The chair now has the pleasure to recognize the gentlewoman from Colorado. She's the chair of the Energy and Commerce Subcommittee on Investigations and Oversight. Great to have you with us, Diana. And she will be followed by Congressman Soto of Florida, because our colleague Jan Schakowsky had to drop off, and then we'll have, I believe, the last member, last but not least, Dr. Schreier. So there is some light at the end of our hearing tunnel here, and so great to have you, Diana, your 5 minutes question, and thank you for your patience and joining us.
Well, thank you so much, Madam Chair, for allowing me to wave on. I feel like I should be an adjunct member of the committee anyway, and I really want to thank all the witnesses for your tenacity and holding on. And I really want to thank you, Anna, for considering this HR 3, because the Oversight Subcommittee, as you know, has had a number of investigations over the last number of years on the broad issue of drug pricing. And this really is a national crisis, as we keep hearing, and it's not getting any better. On this committee know that I'm the co-chair of the Congressional Diabetes Caucus, and this is the largest issue-based caucus in Congress. And we heard about the MS drugs, but diabetes drugs are probably the biggest textbook example of what has happened to patients in America. Because if you're a type 1 diabetic and you take insulin, if you don't get your insulin, you die. And in the past 2 decades, prices for the most commonly prescribed insulins went up from $20 to over $250 a vial, which is more than a 700% increase. And the drugs were the same drugs. And the reason is the way that these drugs are marketed, and because of the inherent markup in the system. And I found this out. See, the problem is members of Congress are actually healthcare consumers themselves. All the members on this committee know my daughter Francesca and have known her since she was like 4 years old, some of them. Well, she was on my insurance, and her insulin cost about $30 a bottle.
Then when she turned 26, she went off of my insurance, of course. She had insurance provided for her by her employer, and she went over to get her insulin after she went on the new insurance. Well, her insulin was not listed on the formulary. So guess what? When she went to get her insulin, it was $312 a bottle for a 26-year-old young woman. And I've had so many people tell me they were working 4 jobs to get their insulin. They didn't know what to do. And by the way, excuse me. And by the way, when my other daughter, who's a doctor, tried to get her a coupon to get that insulin, the coupon only took $20 off. So anybody who says the coupons fix this situation, it is untrue. So I have a couple of questions for our witnesses. The first one's for Dr. Sachs. Dr. Sachs, how would the negotiation process in HR 3 bring down the price of drugs like insulin, which is listed in HR 3, for patients who need them to survive?
Congresswoman, I want to thank you for your leadership on this important issue of insulin because, as you know, HR 3 specifically instructs the Secretary to negotiate for the price of insulin. And we have these decades-old drugs whose prices continue to rise. They cost many times more here than they do abroad. Bringing down those prices would be particularly important for patients.
That's right. And Ms. Humphrey-Ball, I just want to tell you, I thought your testimony was very, very moving because you had the same kind of experience that my daughter and many other millions of Americans have in trying to just live, just to be alive. Now, so what would the impact have been for you if an out-of-pocket cap existed for your medications?
Thank you, Representative Tejeda. I am saying that if I would have had that, my life in the 5 years after I was diagnosed, before I had to quit working, it would have been much easier for me to pay for them. It also is the fact that when you're stuck with you're not getting your drug because of this cost, you have to pick, eat, pay your rent, or get the drug that's going to keep you walking and thinking. So that is what the impact was for me. If we had the HR 3, I would have been able to probably afford my drugs, and that's what's most important.
Well, that's right. I met a young woman who was working 4 jobs to get her insulin.
Yes.
And she was living in her car. It's exactly to what you're saying. Madam Chair, once again, thank you so much. This is such a critical issue. And I would hope that our Republican colleagues across the aisle would work with us. If they don't like HR 3, then work with us to find something that's for real. Because just having a Band-Aid that we say is going to solve something isn't going to actually solve issues like Ms. Humphrey-Ball's, and I yield back.
We all thank you, Diana, especially for your leadership in so many areas, but most particularly in always highlighting the issue of diabetes. And we see you or hear your name, right next to it is diabetes. So thank you. Now I have the pleasure of recognizing the gentleman from Florida, Mr. Soto. Again, another member that has really brought high value to our committee, and we're thrilled to have you wave on. You're recognized for 5 minutes.
Thank you, Chair Eshoo. Let's start with the facts. Americans pay more for our prescription drugs than any other nation in the world. Many can't afford those drugs, and so they go without. What good is having amazing drugs if many of my constituents can never afford them? Here's another fact. The VA hospital, Medicaid, both negotiate their drug prices. They have done so for decades, yet Medicare cannot. That's why we're here today, because you have this big gap between VA and Medicaid negotiating, but why doesn't Medicare? And that leads to higher prices for our seniors. This makes no sense. We've had a lot of our colleagues across the aisle talk about competition for years, except for right now. Why? Why are we not talking about how the competition is not good for Medicare, but it's good for all these other programs? That makes no sense. And then I hear all the scare tactics to get at it. And it reminds me of what we heard back in the 1960s at the founding of the Medicare program. Ronald Reagan said, if you don't stop Medicare, one of these days you and I are going to spend our sunset years telling our children and our children's children what it was once like in America when men were free. Wow, well, that didn't happen. George Herbert Walker Bush described Medicare in 1964 as socialized medicine. Yet you all are rigorously defending the program today. Barry Goldwater, having given our pensioners their medical care in kind, why not food baskets? Why not public housing accommodations? Why not vacation resorts? Why not a ration of cigarettes for those who smoke and beer for those who drink? Ridiculous things were said during this Medicare debate. And Bob Dole, I was there fighting the fight, voting against Medicare. The scare tactics didn't work back then, and they're not going to work now. We have to go forward to make sure that we can increase the access to life-saving drugs for all Americans. And that's what this is all about. And I know I've had countless town halls in my district with Democrats and Republicans and liberal and moderate and conservative areas in my district. And seniors of all stripes, of all political persuasions tell me they're paying way too much. And many of them have to ration their drugs. They have to make sure at the end of the month they take a half a pill or half of what their doctor said because they're waiting for their Social Security check to come in at the end of the month. At the end of the month for the beginning of the second month. So they're rationing that. Some of them are even foregoing groceries in the most prosperous nation in the world. That's what the issue is today. I have a question for my fellow Scarlet Knight, Professor Carrier. One of the areas we've heard some abuses about is in the petitions at the FDA. Professor Carrier, I'd like to follow up on the portion of your testimony in which you discussed a number of reasons why we should move forward with stopping abuses to the citizen petition process. Can you explain why it's difficult for FDA to dismiss a citizen petition currently? Why is it difficult for them to prove both that a petition's purpose is primarily for delay and that there are no valid scientific or regulatory issues raised in the petition? And could FDA's resources be better used if we change that and to an or?
Absolutely. Thank you for the question, Representative Soto. And you're right that a lot of these citizen petitions are filed just to delay generic entry. Everybody knows it. The FDA knows it, but the FDA cannot summarily dispose of these petitions. Why? Because the standards are too high. The standards are, as the FDA says, quote, extremely difficult to meet. That's the FDA talking. Why? Because the FDA has to show two things, both of them. First, that there's a primary purpose of delaying the generic. How's the FDA going to know what the brand company's primary purpose is? It's not going to say in the petition, oh, by the way, we're doing this to delay the generic. So it doesn't really know that. And then the second one is the petition doesn't on its face raise a valid scientific or regulatory issue. There is so much scientific legalese in all of these documents that it's really hard for the FDA to conclude right off the bat that there's no issue at all. And so when you put these two things together, the FDA has never used this power. In its annual reports to Congress, it says that the provision, quote, has neither curbed the filing of petitions submitted with a primary purpose of delay, nor, quote, permitted FDA to dispose of petitions without expending substantial amounts of resources. It's important for FDA to summarily deny frivolous petitions. FDA has never done so. That's why switching and to or could make a really big difference.
Thanks so much. And there's been concerns about impeding a manufacturer's ability to petition the FDA. In your opinion, if this is enacted, would a manufacturer stakeholder still be able to use the petition process for legitimate scientific or regulatory issues, yes or no?
Yes, absolutely. And there's always a sham exception to petitioning. That's what's going on here.
Thank you. My time's expired.
The gentleman's time has expired, and we thank you again for waving on. Now, last but certainly not least, one of the fine doctors that's a member of our subcommittee, and we're thrilled that she is, the gentlewoman from Washington State, Dr. Kim Schreier. Thank you, Kim, for your patience.
Thank you, Madam Chair. Thank you for your patience, and thank you to our witnesses. This is such an important discussion, and while much of our work this past year was really focused on the immediate need to combat the pandemic, the urgent need to bring down the cost of prescription drugs has not gone away for my constituents or any others. And like so many of my colleagues have already highlighted, many of our prescription medications cost far too much, and their prices have continued to increase for no reason, far faster than the rate of inflation, even when nothing about them has changed. We heard about Copaxone and Humira, and insulin is another classic example. I have type 1 diabetes, and so I just want to show you how tiny this little bottle is. 20 years ago, this bottle of insulin cost $40, and now it costs over $300, and nothing has changed about it. That holds 10 milliliters, 2 teaspoons of medicine that I can't live without. And most insulin users use 2 or 3 bottles a month. So this is just one example of why this issue of drug pricing is so important. And that example is particularly egregious, kind of the poster child for price gouging, but the issue is nuanced. And Professor Sachs, you were quoted a couple years ago as saying, we probably are under-rewarding drug innovation for some types of diseases, such as early stage cancers requiring long clinical trials, and then over-rewarding it for others. And I was hoping we could talk a little bit about innovation and that point, because there's a big difference between new life-saving, curative, truly transformational treatments and a second, third, or fourth drug in a class that doesn't really represent a big therapeutic advantage over existing therapies. And I'm from Washington State. Here are a couple things that have happened in my home state, which is a hub for cancer treatments, cell therapies like CAR T, gene therapies. One local company spent more than 8 years pioneering personalized cancer immunotherapy for patients with lymphoma that hadn't responded to anything else by going to a special manufacturing facility, changing cells, re-engineering them to fight cancer. There's also a one-time gene therapy that's showing promise for patients with thalassemia, potentially freeing them from a lifetime of transfusions. And there are countless oncology treatments that meaningfully extend survival and improve quality of life. But research and development is not easy, and there's no guarantee of success, and it can take many, many years. And so I want to talk about the nuance and the use of a scalpel instead of a hatchet in these conversations. Can you tell me, Professor Sachs, how can we better incentivize innovation that represents these therapeutic advances instead of the Me Too drugs that just follow on what we already have?
Thank you for this very important question. I think you're absolutely right to quote my own words back at me, because I don't think that all drug prices are too high and should just be decreased. I think some drugs are priced too high, but others are not. I think we need more investment in certain areas, but we probably have too much investment in some of the Me Too areas, like you mentioned. So in my opinion, this isn't just about the number of drugs that we get, it's about the kind. We want innovation that works for patients. We want cures. And the better a drug is, the more we'll pay for it, and the more we should pay for it. And so all of that really matters in thinking about comparative clinical effectiveness, which is something not just many countries, but also US payers do. We say, is this drug better than the current drugs we have for treating the same condition? If it's not better, maybe we don't want to pay more for it. But if it is better, we should pay more for it. And so thinking...
Right. And even the notion of, what would it cost us over the long run for this patient to have all of these horrible consequences? How much time would they spend in the hospital if we didn't have it? And that's a way to think about whether the cost of a drug is justified. I was just going to ask about HR 3. Can you tell me what guardrails are already in HR 3 or could be added in order to ensure that those innovative treatments are treated differently, that we take into consideration the big benefit? How can we make sure that happens?
Absolutely. So HR 3 already instructs the secretary to think about comparative clinical effectiveness, right? Is this drug better than other drugs for the same condition? If so, that matters as to how we think about negotiating and setting a fair price for that product. HR 3 is also limited to the top spending drugs in Medicare and more generally. So a lot of rare disease drugs won't even be eligible for negotiation, and rare disease patients should have fewer concerns about the impact of negotiating on the price of those drugs.
And they will take into consideration when we have a treatment for Alzheimer's, for example, that will be worthy and valuable and will be treated as such. Thank you, and I yield back.
We all pray for that day. Thank you, Dr. Schreier. Well, I think that we have heard from 41 members, witnesses. So you have really held our attention. I want to thank each one of you on behalf of all of my colleagues today. Each one of you brought great value in your testimony. So a great shout out and enormous thanks to each one of you. Therese Ball, Michael Carrier, Dr. Gupta, Crystal Davis, and Rachel Sachs. You really got to work out there, Rachel, from both sides. But very sincerely, thank you to each one of you. And on behalf of the American people, because they are listening in, and I think that this was a 101 on the subject matter. Now, I need your help, Mr. Guthrie. We have how many? We have 90 documents that I would like to move to place in the record. I don't think that you want to stick around to have me read 90 of them.
I won't do that. So I'll give you unanimous consent.
All right.
Not to read.
Okay. So as ordered, and all the documents that have been submitted to the subcommittee will be made part of the record. Now, pursuant to committee rules, members have, as you know, or may not recall, you have 10 business days to submit additional questions for the record. And as I said to the witnesses, you will be hearing from members. Many of them will submit a written question, and we ask the witnesses to please respond as promptly as you can to any questions you receive. So with my thanks to each one of you, both for the tone, the value of your observations, your questions, the answers of the witnesses, I think you've just been terrific. This has been a rich experience. Yes, certainly.
All right. I think I said I'll give you unanimous consent. I actually can't do that. So I'll move unanimous consent.
I ask for unanimous consent.
Okay, I will not object.
Thank you. Thank you, Mr. Guthrie. Appreciate it. You're so wonderful. Can you imagine if we had to sit here to listen to me read out 90? Where was I? Yeah, I think at this time I can say that the Health Subcommittee meeting of today is adjourned, with my thanks to all of the members and our superb witnesses. Thank you. And everyone stay healthy, please. We need you.